ரொம்ப ஸ்ட்ராங்கான டைப். ஏன்னா கூட்டு போடுறது.
Yeah. A very good evening to one and all of you for the wonderful webinar on UVEA. And very thoughtfully planned out a great set of expert panel and some wonderful speakers, and who are going to take you through the known and the unknown topics in UVEA in a different manner, like dressing it up in a different way. The learning becomes easier and faster for all of us. And I would like to very, very warmly invite our expert panel, Dr. Vishali Gupta, who is to join us soon.
I think there has been a network issue with Dr. Chitra Madam. So a warm welcome to all our expert panelists. We have Dr. Vishali Gupta Madam from PGI, and she is here. We were waiting for you, Madam. Welcome. And then we have a senior specialist in UVEA from Arvind, Dr. Rutina Madam. Welcome. Welcome to the ARC, Madam. And we have Dr. Soumya Basu. We have Dr. Amla. We have Dr. Amit Khosla also here. Warm welcome to all of you, sir. Dr. Rohan Chawla is here, and Dr. Sudarshan from Shankar Nethralaya. So I think...
I heard now?
Yeah, you are heard, Madam. I think we should start with the talks.
Co-moderating with me is Dr. Srinivas Joshi, who needs no introduction, an amazing Director of Research and Community Services from MM Joshi Group of Hospital, and of course, Dr. Partha Pratim, who is again a Senior Consultant Department of UVEA Intraocular Inflammation from Shankar Nethralaya, Chennai, who is going to add great wisdom and strength to this webinar. And without wasting time, let's go on to our first speaker, Dr. Ghazal Patnaik, who's Senior Consultant from Shankar Nethralaya, Kolkata, and he's going to be talking on anterior uveitis, the 5 challenges. So let's hear.
Good evening, everyone. Thank you, Chitra ma'am, for giving me this opportunity. Thank you, mentors, for helping me. And I shall try to keep this talk as much brief, crisp, and a little bit of fun if possible. So anterior uveitis, 5 challenges. To diagnose any case of anterior uveitis, first we need to see whether there is cells in the anterior chamber or not. First, we need to differentiate whether that is pigment or a cell. So as we can see, pigments are brownish in color. They are more closely associated, and they can be seen in other conditions like glaucoma, after trauma, after surgery, after retinal detachment, and even after dilatation also. So first, we need to differentiate between a pigment and a cell. Cells are mostly white in color, and the interparticle distance depends upon the severity of inflammation. Other investigations like gonioscopy also helps a lot in differentiating these features. Second, after diagnosing a case of anterior uveitis, we need to see where, we think what all to investigate in these patients. So let's have few case scenarios. This was a case of young boy with recurrent attacks of uveitis, and we can see there is a thick fibrous membrane over the anterior lens capsule. Just zoom in a little bit more, we see a hypopion lying down. And after ruling out corneal ulcers and endophthalmitis, only 2 conditions specially in uveitis are left with, that is B5, B27 and B51. Taking an appropriate history and investigations, we can narrow down the panel of investigations. Another such scenario, it's never always zoom in to see the keratic precipitate, sometimes zoom out to see other ocular signs, like in this case we see a stromal haze. So this was a case of keratouveitis. Another similar condition with diffuse granulomatous keratic precipitates. Zoom out more and see there is a segmental dermatological involvement of typical herpes infection scars. And this patient, when treated with antivirals and all, developed sectoral iris atrophy after 6 months. So viral anterior uveitis should always be kept in a DD, and we should not always keep on investigating TB, sarcoid, syphilis and all. Another similar condition of a young girl with band-shaped keratopathy and festooned pupil was seen to have this type of deformity in the body. So this was typically JIA, juvenile idiopathic arthritis, uveitis, need not investigate more and has to be dealt with the rheumatologist. So investigation, tailored approach is a must to then a body of investigation. The third challenge is the diagnosis in a very poorly dilating pupil. So we can have a comprehensive ocular examination. When this patient was seen, the patient had a typical acute retinal necrosis features, which was outside the field of view. So most of the cases sometimes have a clinical diagnosis. Eye speaks for itself. Another similar condition most often found with anterior uveitis is a no view or a limited view of fundus scenarios. In these cases, ocular imaging comes very handy. And this was a case of a young male, repeated attacks of anterior uveitis treated with only topical steroids. But when we did an optos, two central retinal atrophic patches were seen in the fundus, and the patient was diagnosed with ocular toxoplasmosis. If optos is not available, at least do a slit lamp biomicroscopy or central visions to know what is the visual potential. There might be a scar standing over the foveal region. Very simple test is the retroillumination, as we can see in this young boy, where the retroillumination showed a decrease in illumination as compared to the normal. The optos again showed presence of subretinal fibrosis with exudative retinal detachment in the right eye and a depigmented fundus in the left eye. This was an ill-treated case of VKH, and other age-old imaging modality like ultrasound can help to detect shifting fluid, and OCT should always be done to rule out any macular pathology. So ocular imaging helps to diagnose these cases, and it is not always topical steroids to treat any case of anterior uveitis. We have to see the patient as a whole to treat the entire spectrum of disease. We have talked so much about the anterior uveitis, but first we need to see whether it is an uveitis at all or not. This was a case of 72-year-old male with complaints of severe pain, and when we see there was a scleral ingestion in the superior temporal quadrant, and the retina showed a serous retinal detachment. It was so bullous that shifting fluid was suspected in the B-scan ultrasonography. The patient initially had an improvement with oral corticosteroids and intravenous corticosteroids, but after 2 weeks, the patient was reviewed again, but there was no improvement in the retinal detachment. Then there was a surgical intervention, and we found that the hole was reaching over superior nasal quadrant, which was not appreciated in the first optos. So it's not always uveitis. Sometimes masquerade should always be kept in mind, and not always neoplastics, non-neoplastic as well. So we began with 5 challenges and saw few case scenarios. And the challenges mainly revolves around diagnosis, investigation, and management with the help of appropriate ocular imaging and a comprehensive ocular examination and a systemic examination as well. We can help overcome this type of challenges in anterior uveitis. Thank you.
That was a wonderful talk, Dr. Ghazal. I'm going to ask a very simple question to Dr. Ratnam, and then the other moderators can take on. How would you differentiate a granulomatous from a non-granulomatous uveitis based on the Cyanike characteristics? You need to unmute yourself. Dr. Ratnam, we can't hear you.
Based on Cyanike, you want to differentiate.
Yeah, I'm asking.
Yeah. Actually, there are several factors that contributes to the formation of Cyanike. If you mean anterior Cyanike, am I audible?
Yes, madam.
Yes,
Yeah.
Yeah.
If it is anterior Cyanike, usually the granulomatous capice will be in the angle, and the Cyanike will form silently, especially in sarcoid. And it cannot be broken by any means other than very heavy dose of steroid and topical steroid with the dilating drops. If it as posterior Cyanike, usually in the case of non-granulomatous uveitis, which is HLA-B27 uveitis, very, very common non-granulomatous uveitis, ring Cyanike forms within 2 days. Whereas granulomatous capes, which is called poppy nodules, granulomatous poppy nodules, usually attach at the site of nodule, not ring Cyanike, not 360-degree Cyanike. And in non-granulomatous uveitis, peripheral anterior Cyanike is little rare. It is only in granulomatous Cyanike, granulomatous entity, peripheral anterior Cyanike is common. So Cyanike wise, 2 form of classification. One is anterior Cyanike, another is posterior Cyanike. Anterior Cyanike common in granulomatous, posterior Cyanike common in non-granulomatous. And it is point attachment in granulomatous, whereas 360-degree attachment in case of active non-granulomatous HLA-B27 uveitis diagnosis. And in case of chronic uveitis, like tuberculosis, broad-based Cyanike. Even though it is granulomatous, we may not see many times granulomas, but it will be broad-based.
Basically, it will be broad-based in granulomatous and more filiform in non-granulomatous, I think, the Cyanike appearance, besides all the very important things you said.
Yeah.
Yes, on to you, Dr. Partho, Dr. Srinivas.
I have a question to the panelist. So what are the investigation actually one clinician should advise in a patient in a patient with viral uveitis? I'll just go to Dr. Amla ma'am.
Yeah, with a suspected viral pattern, with a corneal lesion, raised IOP, recurrences that come up, not all that much inflammation, the diagnosis can be clinical. So if you have access to AC tap and, sending the fluid for PCR, yes, you can go ahead and do that. But the pattern in a viral uveitis is fairly characteristic. So if there is a strong history of periodic raised IOP and very few KPs or no KPs, and maybe even a corneal lesion, yes, go ahead and treat it as viral uveitis. And otherwise, we will, usually if you have access, AC tap along with testing for both varicella zoster virus as well as simplex at the very least.
Many a time we see that people are ordering torch titers if they suspect. So do you think the serological test has any role?
I think there's been a lot of association with raised IOP and toxoplasma also, no? And then the herpes virus group comes with that. But again, torch titers you can do. It's one of the most widely available lab tests. I suppose if you don't have any access to any, you would like to have some information, there's nothing wrong in doing torch titers. It's relatively inexpensive. It's widely available in all the labs. But it can't be relied on. It just can't be relied on. Even Aqueous we cannot rely on. So then why will we expect it from serology?
Very good point. Ratinam ma'am, what's...
Yeah, it is toxo. I have the same view. It is only 12% sensitivity.
Yeah.
So I don't allow the patient to spend money. I don't do ELISA at all. ELISA, IgM or IgG for the 2,200 rupees. No, I don't allow, because as she rightly mentioned, specificity is low, sensitivity is low, and the lab, whether they are using the correct kit, we do not know. Whether the kit is validated in our country, we do not know. So I never order.
Well, before going to the next speaker, I have one more question. I think I'll go to Dr. Amit for that. So in patients with anterior uveitis, when do you recommend or send them for immunosuppressive?
Basically, all pediatric children who are non-infective will require immunosuppression. In the adults, those who are chronic, those who have complication with HLA-B27. See, initially for ankylosing spondylitis and other entities, in India, we are under-treating patients because we don't have access to biologicals. Otherwise, in ankylosing spondylitis, you'll have majority of patients going for their spine and or the back problems for biologicals. But we tend to give methotrexate or azoran before, which doesn't work on the back. So those who have recurrent, who have glaucoma, steroid responders, I would suggest immunosuppression for anterior uveitis in HLA-B27.
A quick question to Dr. Rohan. Sir, in how many of these cases we see In anterior uveitis also, we see around CME in around 15% of these cases. So in how many of these usually we order the OCTs to find out, even though the vitreous is quiet, we don't see much of the posterior segment lesions, but how commonly we do the OCT examination to find out if there is a cystoid macular edema in the fovea?
I would say the clinical judgment is the best, because many times the vision would also tell you, vision in most of these cases would be 6.9 parts, somewhere around that. And if you I also wanted to mention, as the speaker said about optos imaging, so unless you have done a fundus imaging and cleared that there is nothing in the fundus and the vitreous, you will not call it anterior uveitis. So I think for the residents, they should practice even seeing through the small pupil. And for CME, your fundus examination 90D is the best. If clinically you don't feel there is any edema, vision is good, there's no point going for an OCT. But yes, if there is some mismatch there, doesn't correlate, and you are feeling there are some petaloid lesions or some reddish lesion there, then go ahead with an OCT. But like you rightly said, that it's not very common. It's rare to have an anterior uveitis. And regarding the other tests which we were talking about, I would rather say I would recommend not doing them, because they can rather be misleading. So unless you have a typical toxo there in an isolated anterior uveitis, why go ahead and do a titers?
Yes.
Quickly, because we don't have any topic on pediatric uveitis, Dr. Rohan, any tips for treating anterior uveitis in children?
I think Dr. Khosla has already pointed out, and I have seen he's been doing that a lot in his practice with Gangaram. That's the best. You have to put them on immunosuppressants early on. And like you said, even if patient can afford TNF alpha inhibitors for these patients who really don't behave well and become chronic and have developed a lot of complications. And they are silent killers, because the patient does not have symptoms, and the cells and the Cyanike and glaucoma, all these complications can be prevented by aggressive management.
Dr. Amla, madam, can you tell us some tips for treating the pediatric anterior uveitis?
Yeah, again, avoiding steroids is essential. See, especially when it's anterior, you give the minimum amount of steroids to bring it under control. After that, it has to be immunosuppression. And even the topical, as limited or none as possible. I prefer to keep on a non-steroidal and a dilating drop to take care of the anterior segment inflammation. But yes, as much as possible to try and avoid cataract surgery in childhood. So biggest driver of cataract will be the topical steroids. So I would really avoid it in the child.
So in children, we have to reduce any form of steroid while treating a case of uveitis.
Yeah. Shall we go on to our next speaker? Thanks a lot, Dr. Ghazal, for that wonderful talk. And we will be having now Dr. Rohit Modi, who practices at Gokulam Medical Center in Gurgaon East, Mumbai, Goregaon East, Mumbai. And he's going to be talking on the 5 challenges with retinal vasculitis. On to you, Dr. Rohit.
Thank you, ma'am, for the wonderful opportunity. Is my slide seen? Am I audible?
Yes,
yeah,
yes.
Sure. Yeah, thank you. Good evening, my teachers and my friends. Today I'm going to discuss retinal vasculitis 5 challenges. At the outset, I would like to thank my teachers, Dr. Basu, Dr. Behra, and Dr. Paddy, the whole LVPI network. Dr. Partho sir has been a mentor, a friend for a very long time, and Dr. Kaza for his various discussions, in uveitis, ARC and AIOS, my spiritual team, SSY, and family, and especially my patients. Retinal vasculitis was first described by the British surgeon John Hunter way back in 1784. And he described as a perivascular sheathing of retinal arteries and veins. And we know it is characterized by staining or leakage of vessels in most cases, what we see in FFE. Now, the first challenge is we need to differentiate it by the systemic vasculitis, because systemic vasculitis is not visualized directly, whereas retinal vasculitis is. Systemic is mostly arteriolar, whereas retinal vasculitis is mostly venular. And we see uncommonly vessel wall destruction, which is commonly associated with systemic. And systemic is mostly diagnosed on histopathology. And whereas the etiology of retinal vasculitis is common, infectious as well as non-infectious, whereas for systemic, it is mostly non-infectious. Another challenge is how to approach a case, because there's a wide amount of etiologies concerned. My favorite is the step ladder approach, where we see the patient's profile, age, and gender. Thereupon, understanding the patient's profile, we differentiate whether it is a venous predominant or an arterial predominant. If it is a venous predominant, we look at the associated fundus findings, such as if there is a retinitis patch, if there is a chorioretinitis patch, or there is vitreous inflammation, or there is no other lesion. For the arterial predominant, we look at whether there is presence or absence of perivascular sheathing. Now, if it is associated with a retinitis patch, we need to think in terms of infection. Probably it can be toxoplasmosis, viral, or tuberculosis, rarely Behçet's. If there's a chorioretinitis patch, especially a punched out heat lesion, we may be thinking of toxoplasmosis. Or if there is a subvascular chorioretinal atrophic patch, we can be thinking of tuberculosis. Whereas if there is a presence of arterial predominant retinal vasculitis with perivascular sheathing, we are thinking in terms of infection such as viral. It can be CMV if the patient is immunocompromised. If there is no sheathing, we are thinking of SLE, Takayusus, or Susaks. Let us look at a case. This is a 20-year-old female who presented with sudden drop in vision in the left eye. Right eye was unremarkable. Left eye had some vitreous inflammation. There was vascular occlusion. We can see a subvascular focal lesion over here. On further evaluation, HRCT thorax with contrast showed enlarged lymph nodes, which enhanced on contrast, and the biopsy revealed rifampicin-resistant MTB. She responded very well to intravitreal anti-VEGF for the macular edema, and AKT was given by the chest physician. Her vision improved from finger counting to 6/9 at present, post 2.5 months of therapy. This is another patient who was on 4 months of treatment and was on immunosuppressants. She had perivascular sheathing and associated retinitis patch. She was immunosuppressed because she was diagnosed 4 months back with VKH. This is a typical patient of VKH. 3 months into therapy, responded very well anatomically and functionally. Her vision had improved to 6/12. But at 4th month, she developed viral retinitis, and post intravitreal ganciclovir, she recovered well. So this shows how a tailor-made stepwise approach can help us diagnose and treat the patient accordingly. Another challenge is that we know that a significant percentage of patients in our practice do have tuberculosis as an etiology. So if we have certain telltale signs which can help us guide and increase the positive predictive value, that will really be helpful. And these are described by Kaza et al. Is vascular occlusion, occlusive. It can be a focal subvascular active lesion in this case, or a heat lesion, or there can be a focal vascular tortuosity. A combination of focal subvascular lesion and a focal vascular tortuosity can give us a positive predictive value as high as 80%. Obviously, we cannot take these in isolation. The role of ancillary test is important. And in this patient who had come to us with a finger counting vision and RAPD, there was a confusing sign because it was a large optic disc, granuloma, but a focal subvascular heat lesion helped us diagnose the patient with tubercular etiology. And subsequent treatment gave us a favorable structural outcome, though the vision only improved to 20/400. Another entity which is used and sometimes confused is the Eels disease. Now, Eels was described by the British ophthalmologist Henry Eels. He thought it was non-inflammatory, thought it was vasomotor neurosis. He was corrected by various researchers later. And with a better understanding, with better clinical and research methodologies, we know that in significant percentage of these patients, tuberculosis has been found out in PCR in the ERM samples. Also, some people believe it is hypersensitivity to tuberculoprotein. So might as well as we can call these patients in which we are sure as tubercular retinal vasculitis or in patients in which we are still investigating undifferentiated retinal vasculitis as compared to Eels disease. The last is, this is a patient who had come with sudden drop in vision, and the cause was pre-retinal hemorrhage right at the fovea. We could see some rod spots, and the patient had superior temporal retinal vasculitis. Though on FFA there was no staining or leakage, further investigation revealed that the patient had CML. So this patient really didn't have retinal vasculitis. Thank you.
That was a brilliant talk. If I could enjoy it so much, I'm sure the UVEA persons all around would have learned a lot from you. And I think I would take this question with Dr. Sudarshan. How would the manifestation of retinal vasculitis be in Behçet's disease, Dr. Sudarshan? Some important points there.
As excellent talk, Rohit. Actually, his points were so, particularly he was stressing on the point that which are the type of vessels that are involved. Especially in Behçet's, we keep telling that it is a pan-vasculitis. So all the vessels are involved, and occlusive vasculitis. It is even the classical fern tree appearance or ferning pattern in FFA is because of the capillaritis. So every vessel, if it is involved, and early occlusive vasculitis in a pan-uveitis and a non-granular type, then probably you are dealing with the case of Behçet's. The same occlusive vasculitis can be seen in tuberculosis, which are predominantly venous, and he added those very specific points by LUP group only, like subvascular lesions, occlusive vasculitis, and a CRA adjacent to a vessel or an Eels-like profile. So all this come under a granulomatous panuveitis, then you're probably dealing with the tuberculosis. In a non-granulomatous with an occlusive vasculitis, with a pan-vasculitic approach, including even the capillaries, then probably it's Behçet's.
Oh, wonderful. Yes, Dr. Srinivas, Dr. Partho.
Yeah, Amla madam, I had just one doubt. And in most of these cases of post-fever viral retinitis, we see most of it in our areas here in the northern part of Karnataka. So many people have different approach when the wheel felix come positive, especially the OX19 titers, if they come positive. Then we usually start them on the doxycycline. But after a few days, some people, some authors, doctors prefer to use steroids as well. So what is the usage of these steroids in these? Especially just today I had a case of again the post-fever viral retinitis, one eye 6/24, the other eye is showing a lot of retinitis with cotton wool spots involving the macula. So do we at all start steroids in these cases, or are we just going for the doxycycline? Because the another case which I had seen where the hard exudate clumps, we did not give steroids in that case, just gave a doxy. But the clumps started coming and forming over the fovea, and ultimately the child lost vision. The clumps got for. So probably giving these steroids will decrease the inflammation in these kind of post-fever viral.
Yes, they do decrease. See, the role for steroids in any post-fever viral or any is the where are we doing the greater good, or where will the greater harm come? See, if you look at neurology, they add steroids for virtually every infectious disease thing, because the danger of not adding the steroid causes, life-threatening situation. And we can use the same rule for ophthal in terms of these are vision-threatening situations. So in a mild attack, yeah, you probably have the time and you can afford to not give the steroid. But when it's vision threatening, you have to give the steroids pretty early. We've had very bad case of arthritis post leptospirosis, which you have to treat with steroids right in the beginning. Others we've lost. We've had children lose both eyes, that bilateral NPL and all that.
So you want to start it with the doxycycline, or you just wait after giving doxycycline for a few days and then going for the oral steroid?
See, usually these are coming from the physician's side. There is an active fever or an episode and the patient's already on treatment, at which point people realize that the vision is lost. So this happens within a few days or maybe a week or so. By the time the clinical situation is already sort of under control. And we're not really starting the steroid on our own. We've got the pediatricians okay for it. And they also understand that this is a vision-threatening situation. And they're fine with us going ahead with the steroids, even intravenous steroids if required, because that's what they do in serious infectious disease, for especially like, they're actually quite okay with us adding steroids when required. And usually when it's an arterial occlusion or, the optic disc is going or there's a lesion near the macula, it makes sense to add the steroid. But all of this is being done in coordination with the pediatrician, whoever's and the
Vishali madam, are you there? Many of them have even started using the Avastin left and right. These major of the cases where there is macular edema. Few of them have compared the IVTA giving Avastin in these cases where there is a macular edema post viral retinitis. And they have found out, of course, the IVTA has its own course of the steroid-induced responses. But they have even found a good response with IVB without even giving steroids. So how far is it rational in giving these anti-VEGF drugs, or it is just that it's taking its own course and the patient is improving on these cases? Khosla sir or Vishali ma'am?
Yes, we don't have randomized clinical trials to say what is better or not, but it's anecdotal. We all are giving, if you don't want to give steroid and there's a macular edema, you're not responding to oral steroid, then you might think of using Avastin or Lucentis for the edema. So macular edema is never an emergency in UVEA. It's not side-threatening. You can wait for a week and see. While optic disc or retinitis involving the center is more emergency. You can wait for a week, and if it doesn't respond to oral steroid, then you can think of giving an intravitreal. And you always want to avoid, in a doubtful infectious case, to give intravitreal steroids. You can give Avastin.
Yeah, I have a question for Ratina ma'am. I want to simplify some topic here, already discussed by Rohit very nicely. So, ma'am, there is a lot of confusion between the terminologies like Eels disease and tuberculous retinal vasculitis. So, both of these are very common in Indian subcontinent, and sometimes these terminologies are interchangeably used. So, how to approach this confusion? I mean, how to differentiate between Eels disease and tuberculous retinal vasculitis?
Can I answer this one?
Yes, Dr.
You are back.
Yes.
Yes.
That's very sweet.
By definition, retinal vasculitis in Eels is a primary retinal vasculitis, which means there is no uveitis. It is only vasculitis. And vitreous will be very, very clear. And you will see the vasculitis and vascular occlusion and neovascularization. That is entirely a different picture from tubercular retinal vasculitis, because in tubercular retinal vasculitis, most of the time we will have KPs, we will have vitreous cells, and the sheathing will be there, not occlusion. Whereas Eels, it is occlusion and neovascularization. In TB, rarely we see occlusion and neovascularization, and the exudative vasculitis in TB, occlusive vasculitis in Eels, something like your Behçet's. But the only difference between Behçet's and Eels is Eels always have neovascularization. Behçet's occasionally, very, very rarely have neovascularization. Both are occlusive, and TB is exudative retinal vasculitis.
I'll go to Vishali, ma'am.
Like Dr. Ratinam said, but also if you look at the definition of eel by Henry Eels, it's the idiopathic retinal vasculitis. The moment you find a cause to a vasculitis, which is tuberculosis, that is out of the definition of Eels. For me, it's as simple as that.
Nice, ma'am. Ma'am, just you are not there. There was an important discussion by important point raised by Dr. Srinivas, and we have got an answer also. So when one should think of injecting intravitreal anti-VEGF in Eels disease or in any retinal vasculitis, what is your take?
I always do wide field optofluorescence angiography, and if you see a bunch of new vessels, which are, if it is NVD, that has a more likelihood of bleeding into the vitreous cavity, and I would inject anti-VEGF straight away. If it is at the border, because most of the times it's going to be at the border of the perfused and non-perfused retina, then I look at the character of those new vessels. If they are just mature and they are not elevated and they are not growing along the hyaloid, I would just do the laser and wait for them to regress. But if I see a pre-retinal bleed, some hemorrhage already into the vitreous, or you see the frond is elevated and is going to grow along the hyaloid, that frond has the chances of getting a bleed in the vitreous and will not, probably the laser will take about 2 months to work and it might bleed in the meantime. In that case, I would give anti-VEGF to take over the period till the time laser has become functional.
Other than the neovascularization is what we also wanted to ask on. Say, for example, for macular edema, do you at all inject in case of NIUs in any of these cases? Or
in macular edema, we are coming up with the results of the largest trial, MERIT trial, where it was Harvard, we were just the participating center. Comparison between Ozurdex, methotrexate intravitreal, and anti-VEGF. Methotrexate does not work. Anti-VEGF do not work as well. Only thing which works well is intravitreal Ozurdex. However, recently there have been reports of use of intravenous tocilizumab, which works very well for uveitic macular edema. And now even intravitreal tocilizumab, I mean, it's not published as yet, but these are the therapies which are coming up for macular edema.
Thank you very much. We shall now go on to our next speaker, Dr. Navneet Malhotra, who's a vitreoretina and UVEA consultant from Retina Foundation and Asopolov Eye Hospital from Ahmedabad. And he's going to take us on to another interesting topic, which is 5 challenges with VKH. On to you, doctor. I think, Srinivas, we'll have to watch our time in case the discussions are going further. You stop me.
Yeah. Am I audible? My slide is visible?
Yeah.
Yeah, thank you, ma'am, for giving me an opportunity to present my me on VKH disease, 5 challenges. So, starting with a small introduction about the VKH, it's a bilateral granulomatous panuveitis, which is with or without extraocular manifestations. The most commonly it was originally classified as Cyanike and Harada's disease separately, with presence of chronic severe anterior uveitis, alopecia, poliosis, cutaneous, as well as perilimbar vitiligo and dysesthesia. Harada's was bilateral exudative uveitis, more common in patients with pigmented skin and females with in 2nd to 5th decades of life. This is one of our patients with bilateral multiple serous detachments, and there was a left eye, we could see there was an exudative detachment, and when we did angiography, we found that this is a case of VKH that I will show later. As there are different stages of VKH: prodromal, acute uveitic, chronic or convalescent stage, or recurrent stage, and based upon the diagnostic criteria, either it may be complete, incomplete, or probable VKH. So we actually did a study of VKH patients in our center, in which we looked into the clinical spectrum and management of VKH in Western India. There were 26 patients, and all patients underwent all examinations, FA, ICG, fundus photography, and all investigations for TB, sarcoidosis, and syphilis vernon. So starting with the challenges, with what we usually face in these patients, and what I found in our study also. So the most important is the first challenge is the diagnostic challenge, whether it's the most important differential diagnosis is CSR, whether it's a CSR or VKH. we found that there are three major studies in which they have tried to differentiate between CSR and VKH. One was by Shen et al., in which they found that PED in CSR and optic disc hyperemia in VKH had the highest positive predictive values. And Lin et al. Found that presence of subretinal septae and folds of retinal pigment epithelium were seen only in eyes with acute VKH, and CSR had significant PEDs and bulging of retinal pigment epithelium. Anirudh Agarwal et al. Also showed that there is a bacillary layer detachment in swept source OCT. Other thing what we have seen that if we do fluorescein angiography and ICG in FA, in CSR we see either ink blot kind of leakage or smokestack kind of leakage, but in cases of VKH we find multiple pinpoint leakages, but with corresponding ICG we could see multiple hypofluorescent hypocynescent lesions which are suggestive of inflammatory granulomas at the choroidal level, stromal choroiditis, suggestive of VKH. Second challenge is the use of immunosuppressants. In our case, we started all our patients with steroids as a first line of treatment, and with high dose intravenous methylprednisolone. 10 patients were started on immunosuppressive agents at presentation along with steroids based on the severity of disease. 17 of the 26 patients, that is 65.38% of the patients were started on immunosuppressive agent during the course of disease. That means like 65.38% of patients needed immunosuppressive agents. Only 9 patients didn't show relapse, which were on steroids only. So slow taper of steroids over 6 months. This becomes important because there are many newer studies which show the importance of use of immunosuppressants in these patients right from day one of the diagnosis of disease, because early treatment with immunosuppression have a better results in long term and less complications like sunset glue fundus and subretinal fibrosis. 8 patients of our study showed relapse of disease on one immunosuppressive agent. So there may be at times need to add more immunosuppressives. In our study, we started with azathioprine as a first drug, but with time now we have started using mycophenolate and cyclosporine, but at time there may be need for addition of another immunosuppressive agent. Biologic was given to 3 patients. These patients had relapse on 2 immunosuppressive agents. Some eyes show no recurrence with steroids only, some with 1 immunosuppressive agent, but few may need biologic therapy for suppression of disease. This is a point of discussion always, but there are many new studies which are coming up which shows that we should start immunosuppressive agents early in these patients. The third challenge is sunset glue fundus or subretinal fibrosis. In our study, 1 patient developed subretinal fibrosis due to non-compliance. 5 patients developed sunset glue fundus at the end of follow-up. 3 of these patients were started on combined steroids and immunosuppressive agents who developed sunset glue fundus, and no patient developed CNVM. Sunset glue fundus developed due to chronicity of disease, and early use of immunosuppressions may prevent this complication. Another is the challenge is to look at the complications which develop in these patients. 6 patients developed cataract during the course of treatment. 2 patients developed pupillary block glaucoma. 1 patient developed TB, and who were on 2 drugs of immunosuppressive agent, and 1 patient developed stage 1 osteonecrosis femur of head after 4 years of irregular treatment. Good visual recovery was achieved after cataract surgery, and these patients were operated after 3 months of inflammatory control. And surgical peripheral retectomy was done for glaucoma because multiple attempts of YAG retectomies were unsuccessful in these patients, and there was repeat high spike of IOP. So when and how to stop treatment? In most cases, steroids were given in a slow tapering course over 6 months. In case of relapse, steroids were stepped up with addition of immunosuppressants, and topical steroids were added in cases of anterior uveitis. Immunosuppressants were continued for 6 months without any relapse before tapering, and wide field angiography, especially ICG angiography and choroidal thickness using either EDI OCT or ultrasound was done to decide about tapering of immunosuppressant. So to conclude, VKH is an important cause of bilateral loss of vision, and good vision is preserved with aggressive therapy and regular monitoring.
Thank you. Thank you very much, Doctor. That was a wonderfully detailed talk. I think I'll just take one question, and I would ask Dr. Rohan Chawla. Could you tell us how do we, he's already been discussed by Dr. Navneen, but how would you prevent recurrences in VKH, a broader outline?
So like you already told, VKH is a very chronic disease and one needs to treat it very aggressively. It is one of the indications where you can start primary immunosuppression itself at the first go, the first attack itself, along with the steroids. But then you have to see the patient profile, whether the patient you feel is fit for immunosuppression, can regularly go for blood test, is not in the childbearing age and other factors. And if you plan to treat only with steroids, then like I said, a very slow taper is to be done. So after your dose is little less, say around 30 milligram or something, then don't step down by every 10 milligram every week or every 2 weeks. You have to even make it lower, step down by 5 milligrams, or even then later step down by 2.5 milligram and continue low doses for months. Like I would probably give 15 milligram or 12.5 milligram for a few months, then 10 milligram and 7.5 if I don't want to give immunosuppression, and try to maintain the patient on a dose less than 10 milligram of Viacilon for a long time. So that will help me prevent recurrences. And the other point, he said that if we have put the patient on immunosuppression, he said you would discontinue in 6 months. I would not agree with that. If you have already put on immunosuppression, then that means immunosuppressive agents other than steroids, then they have to continue at least for 2 to 3 years. Only then probably I would want to step down on them if we have already taken a decision for immunosuppression. Since this is a chronic disease and the more aggressive and treatment that we do, managing the side effects, better outcome would be.
May I come in for a minute?
Yeah.
Actually, I meant for 6 months is like when all steroids and a disease-free interval, like everything like OCT and even angiography showing no signs of any inflammation. Following that, if the period of 6 months and then slowly tapering. So it goes to the period of around 1.5 to 2 months, or maybe up to 2.5. Sorry, 1.5 to 2 years, or maybe up to 2 more than that.
Okay. Dr. Partho, Dr. Srinivas, anything before we go?
Immunosuppression is required for VKH. So I have a common question for our panelists. So how to approach a follow-up patient of VKH who had completed all treatments and the disease is quiescent for a long time and the patient is not on any treatment, and suddenly the patient comes to our clinic with anterior uveitis and there is no clinically detectable posterior segment signs. Now, how to approach this patient?
Whom do you ask? You need to tell, no, Partho? Direct it to a particular expert.
Professor Ratinam. Ma'am,
yeah. Dr. Basu.
Actually, this is a very tricky situation. Dr. Chi-Chun Payak has published a paper whenever there is anterior uveitis recurrence, there is also a pigment loss in the posterior segment. So, even though we don't see the clinical sign, the paper concludes that the anterior uveitis is associated with pigment loss in the posterior segment and sunset glow gets increased. So we have to keep this in our mind. And if it is 2 or 3 KPs, what I usually do is I give topical steroid and oral steroid. I make the patient come to me again and keep the patient on very close follow-up. If the recurrence is too many times, like whenever I reduce the steroid, if the patient develops KPs, then I put them on immunosuppressant. There are few patients who will come and topical steroid, oral steroid, it disappears and they are very, very normal. In those patients, I don't restart steroid, immunosuppressant. Have I answered your question, Partho?
So coming to Vishali ma'am, any take on this?
For me, the majority of the patients that are being treated very aggressively these days, like Rohan said, MMF, Azoran started on day 2 itself, do not really develop sunset glow. So even when they develop anterior segment recurrence, there is still very good fundus behind. So I would do my swept source OCT and compare the thickness to the previous visits. If it is more than 50 micron increase, because that is something I would just keep as a inter-visit or inter-observer variation. If it is increased in the thickness and ICG shows the appearance of dark spots, I would take it as a posterior segment subclinical disease, which is active, and would restart on systemic therapy.
So for our audience, so you have to investigate this patient and go for imaging to look whether there is any reactivation on the posterior segment. Even clinically, there is no signs of reactivation.
Then a very important question, a very basic question. What are the OCT signs of VKH?
The OCT shows diffuse choroidal thickening in the posterior pole. That is the only sign. But that is the actually preclinical sign. And then you do have serous detachment, which are very classical because there is basilarly layered detachment, which we reported happens in almost 80% of the cases in VKH because it's a very acute event. And you see multiple pockets, which you do not see normally in other situations. So these are the acute phase. If it is gone into chronicity, you may have choroidal atrophy, but that is if you have not treated it nicely. If you treat your VKH patients nicely, there is no reason for sunset glow or choroid to undergo atrophy.
Thank you.
Also, we do have them choroidal undulations as well.
Yes.
In these.
Choroidal undulations, yes.
So sometimes there is a confusion between posterior scleritis and VKH, specifically if it is unilateral, no, like asymmetric. Now, how to approach such confusion?
An MRI for scleral thickness if it is atypical. VKH is not going to be unilateral. So ICG is going to show some signs in the opposite eye. You know, the choroidal thickness in the opposite eye may not be normal, but there is nothing like unilateral VKH. So if does not seem typical, get the ultrasound for T sign and MRI for scleral thickness.
Right. Thank you. We shall now go on to our next speaker, Dr. Richa Perry, who's a UVEA and retina consultant from Shroff Eye Center, New Delhi. And she's going to be talking on 5 challenges in choroiditis. On to you, Dr. Richa.
Thank you, ma'am. Good evening, everyone. My name is Dr. Richa, and I'll be speaking on 5 challenges in choroiditis. Of course, is the diagnosis of choroiditis. Choroiditis diagnosis is actually twofold. There's a morphological diagnosis and there is an etiological diagnosis. An understanding of the different morphological variants of choroiditis is the first step in the pattern recognition, and which leads to an etiological diagnosis and coming up with an appropriate management protocol. So if we see the different morphological variants, there can be multifocal choroiditis, there can be serpiginous-like, APMPP, amphigenous, and relentless placoid choroidititis. Etiological diagnosis, in our country, of course, TB looms large. The main clinical challenge that we have in India at least is differentiating TB-related choroiditis with a sarcoid-related choroiditis, and we'll be tackling that in the subsequent slides mostly. I'll be focusing my discussion on that. So, like I said, different morphological features that can point us towards a TB-related choroiditis are, of course, classically the serpiginous-like choroiditis, multifocal choroidal lesions of varying shapes and sizes, which often coalesce to form a diffuse choroiditis, which resembles a serpiginous choroiditis, but is not discentered, frequently spares the fovea. Now, solitary granulomas can also happen in tuberculosis. These tuberculomas usually heal with pigmentation. And there are typical signs that we can see on OCT and other imaging, which I'll be discussing later on. In case of multifocal choroiditis, like already discussed by previous presenter, the patches are frequently perivascular. Now, as far as ocular sarcoidosis is concerned, the presentation is not very consistent, and an exclusion of TB by lab investigations is often necessary to establish the diagnosis of sarcoidosis. Now, diagnosis of sarcoidosis, according to this paper by really good paper by Babu et al., a diagnosis of sarcoidosis should be considered in patients with dry eye, which can be checked by Shermer's testing, bilateral intermediate or posterior uveitis with candle wax phlebitis, the presence of snowball or string of pearls appearance of vitreous condensation, or multiple small clustered chororetinal granulomas which heal with depigmentation. For example, this photo which shows depigmented healing of the choroidal granulomas. These are all indicative of sarcoidosis. Now, this study also found that there are this study by Agarwal et al. Also compared granulomas of TB and sarcoid, and they found that large, solitary, intensely yellow granulomas were more commonly associated with tuberculosis, and multiple smaller granulomas were associated with retinal vasculitis are more significantly associated with sarcoidosis. So this perivascular sort of picture of Corroditis is more typical of TB, and the picture on the top you can see multifocal Corroditis which are coalescing to form a serpiginous like Corroditis. Moving on, take a step back from the diagnosis, put a pin on it for now, because our second step in Corroditis management and hence the second challenge is appropriate testing. Like already mentioned before, tailored testing for uveitis is essential. So all routines, including blood sugar and KFT, should be ordered. Blood sugar because likely the patient is going to need oral steroids, and contrast-enhanced CT is the preferred form of chest radiography for a lot of for differentiating TB and sarcoid. So KFT is required. Now, serum angiotensin converting enzyme is reported to be elevated to 40 to 60% of patients who have sarcoidosis. In India, a study from India showed that it was positive in 58.9% of cases with sarcoidosis, but this is a relatively lower sensitivity for sarcoid diagnosis. Negative MAN2, on the other hand, was seen in almost 93% of cases of ocular sarcoidosis, and a negative QTB gold test was seen in almost 84%. Now, all of these signs together, therefore, can come, you have to do a pattern recognition. You have to put all of these clues together to give a clinical lab plus imaging diagnosis in cases of these very tricky TB versus sarcoid cases. So this is the study I was talking about. Now, going on to tissue investigations, you can, of course, test anterior chamber samples, vitreous samples for PCR testing. PCR can be used to target specific genes for TB, for example, IS6110, MPB64, and protein B. Now, the reported diagnostic sensitivity for single target is low, somewhere between 40 to 60% again. However, an approach utilizing multiple genes has reported an increased sensitivity of 77%. Now, but this very important paper by the COTS study group has shown that despite this simultaneous amplification, more than 30% of patients who tested negative with PCR in ocular samples were actually diagnosed with systemic TB, including one patient who had miliary TB and one patient who had TB meningitis. This highlights the sensitivity, the reduced sensitivity and the limitations of this approach. Moving on to chest radiography. Now, here most people would agree that CT is superior to chest X-ray. However, which type of CT scan to order is very important. Non-contrast HRCT scan can delineate multiple parenchymal findings to differentiate between sarcoid and TB. Contrast enhancement, however, gives additional imaging clues relating to the lymph node status. Now, radiologists help. This can help radiologists judge which side of the border they are falling more on. Bilateral hilar lymphadenopathy and fisural nodes are significant findings in ocular sarcoidosis. However, a hypodense region with a rim enhancement is very typical for TB. And these are the studies I've quoted in this slide. Now, moving on, Bansal et al. Have also used contrast-enhanced CT and concluded that in systematically asymptomatic individuals presenting with uveitis, CT chest established the diagnosis of TB or sarcoid in more than 71% patients. Ocular investigations to which ones to order and when. So I think most people agree that for diagnosis activity, FFA, ICGA can all detect activity. OCT, FFA, ICG all have described findings to help them distinguish between TB and sarcoidosis. For follow-up, autofluorescence is a non-invasive and effective way to track healing. Lesions usually go from hyper-autofluorescent to iso or hypo-autofluorescent, especially in cases where there is pigmentation of scarring. Now, certain very typical findings of on OCT. Now, all choroidal granulomas can show homogeneously hyporeflective internal pattern with an increased signal transmission. However, contact sign has been described in OCT in TB, where an area of RPECC complex contact with the localized retinal layers is seen. RP disruption is seen in that area. There can be hyperreflectivity of outer retinal layers in that area. A similar finding has been described by Anurag Agarwal et al. So this is a case from one of my clinics. You can see that the RP-CC complex is touching the retinal layers, and there is a localized disruption along with FRS. Now, AF again demonstrating active edges with a healing center in a patient with TB macular choroiditis. So again, another paper which is showing which is shown helpful comparative parameters between FA and ICG. Now back to the first challenge which we had left hanging, the diagnosis. Yeah. So basically, we have to we use tailored testing in the presence of typical clinical phenotypes. This two-step testing will improve our likelihood of correctly identifying the underlying etiology. Now, ATT, everybody has now agrees that ATT significantly reduces the chance of recurrences in cases of TB-related choroiditis. What is the role of systemic steroids? Of course, all patients with TB or sarcoidosis must be started with systemic oral steroids at 1 mg per kg with a tapering course, immunosuppressive if there is recurrence. What is the role of Ozurdex in TB? Dexamethasone sustained release implant has a role in patients where probably the systemic conditions preclude oral steroid therapy, or they can also be given in patients in paradoxical worsening as an add-on to systemic therapy. So these are multiple papers which have demonstrated the efficacy and the safety of dexamethasone implant in TBU when given in along with ATT. So again, now what is the role of anti-VEGF? Now, anti-VEGF, basically large tuberculomas can show resistance to treatment because of abnormal vascularization, feeding the lesion, and this can also help in maintaining the inflammatory process. Hypoxia is a characteristic of the core of these tubercular granulomas as well, which can drive the VEGF load. Now, these are all reasons why adjunctive use of anti-VEGF can be helpful in dealing with a tubercular granuloma. What is the follow-up plan? For most patients, clinical response can be seen in 4 to 6 weeks of initiating treatment. Paradoxical worsening can be seen in almost 50% of patients post-ATT. Now, paradoxical worsening is difficult to manage for most of us. Worsening despite ATT and steroids can be seen in almost 40 to 50% of tubercular granulomas. This may be due to a few possible reasons, assuming the etiological diagnosis of TB is correct. This may be a paradoxical reaction, a delayed response, or resistance to ATT. Now, the study by Gupta et al. Has concluded that 14% patients show continuous progression and despite a mean steroid dose of 50 mg per day. In these patients, either the steroids were stepped up orally or additional immunosuppression was added. The increased dose of steroids was continued over the next few weeks until all lesions healed and then slowly tapered over the next 12 months. Basu et al. Also concluded that escalation of steroid or immunosuppression is usually required for these patients. This escalation was done both as systemic and as local depot steroid injection. The conclusion, of course, challenges abound in choroiditis. To overcome these, we need evidence-based medicine, more hands-on clinical experience, and sessions such as these where we can learn from other experts. Thank you. I'd like to thank Partho sir and Chitra ma'am for this wonderful opportunity. I am done with the presentation now. Floor is for the experts.
Yeah, that was a high speed and wonderful presentation. And I think you tried your best to put in all the contents. I have a very basic, very basic question. Dr. Basu, you're there? Is he there? Dr. Basu is there? Not there. Okay, Dr. Amit Khosla, I have a very basic question. Why would you want to differentiate a serpiginous choroiditis with a serpiginous tuberculous choroiditis? What is the basic need to differentiate it?
Basically, this is based on the premise that serpiginous-like choroiditis occurs more in tuberculosis, and the serpiginous starts from around the disc, while the serpiginous-like will have anterior segment reaction, can have vitreous haze also. So the aim is to differentiate, but both require steroids, and in addition to the ATT for serpiginous-like. For serpiginous-like, we always felt was infective, but the present studies showed more of an immune reaction. It's not an infective etiology of TB. And the aim of giving ATT in serpiginous-like is to prevent recurrence, not to treat serpiginous. That will only be recovered with steroids. So there are studies which says even Ozurdex has been given, you can give immunosuppressant. Sometimes you have a surface-like corroditis which keeps recurring despite giving ATT, and you require immunosuppression for 1 to 2 years. So both will require immunosuppression in addition to the ATT in surface-like corroditis.
Oh, okay. I was under the impression that more immunosuppression is needed in a serpiginous corroditis, and you need to differentiate from tuberculosis so that you don't end up reactivating a tuberculous infection.
No, but the surface-like corroditis is also immune reaction, and even after 9 months, it can still be active because it's an immune reaction. It is not an infective. So it is just to prevent recurrence. You have a latent TB somewhere in the body, and you don't want it, because if you were to give ATT with it, you sometimes have a paradoxical reaction, which is worsening. If you have a worsening, it means it's an immune reaction to TB, not an infective etiology of TB.
Yes. Dr. Partho? Dr. Partho, are you there?
Yeah, I'm there.
Yeah.
So I have a question to our panelists, that do we need to perform both Montu test and quantiferon TB Gold in patients with Corroditis? And second, how many of you advocate chest X-ray nowadays?
The question is asked towards whom?
Yeah.
Partho, you need to tell.
Yeah, as far as possible, I avoid X-ray chest. I directly go for CT chest. If patient cannot afford, not willing X-ray chest, but otherwise it's only CT. In fact, I do CT chest and ultrasound abdomen also to see mesenteric lymph nodes. And your first part of the question is, what is the first part of the question?
Do we need to perform both Montu test and quantiferon TB Gold?
Our government, each government has taken decision, and Indian government says that Mantu is enough. Whereas in America, USA, they do both, and if it is positive in one, they take that as positive. Whereas in Europe, they have concluded that it is only IGRA, no Mantu. So it depends upon the country. What I do is usually only Mantu, because it's very affordable by the patient, and I want to see the patient again with lab test and CT. So anyway, I'm going to see the patient in 2 days, so I stick on to Mantu. And some patients, they read in Google and they want to have IGRA done. In those patients, I go with them because I don't want to end up in a court case. So I do both. Only in patients when they ask for IGRA.
Amla ma'am, you want to add something?
Yeah, I prefer to order both in case we're ordering it. Before we start steroids, let's get this confusion out of the way, because afterwards it's difficult to find out. So if you haven't started steroids, get man-to-man, quantiferon, and the imaging of your choice. Chest X-ray is fine if there's not much of a suspicion. And again, I prefer to get the infectious disease people involved at this point, because very often they have a different perspective, and the patient often has to spend money from their point of view also. So the issue of a CT scan or whether a patient has systemic tuberculosis, I prefer to leave it to the infectious disease people first and foremost.
So my last question to Vishali ma'am, if there is recurrence of Corroditis even after completion of ATT and a course of oral steroid, then how to approach?
I think that's a difficult question, and we all have about 20% of our patients where we have given ATT and they continue to recur. The first thing was it was not tuberculosis, and the tests for TB were incidentally positive, so they require immunosuppression. The second is, which Soumya believes a lot, is the reinfection of tuberculosis. So it's very difficult actually to differentiate reinfection from reinflammation. So that is something we really do not understand. But in my practice, I almost never start a repeat course of anti-TB drugs. I do get a PET scan done in these patients, and I have 2 young students, actually both from Delhi, researchers, who had a focus in the parotid gland, which was earlier diagnosed as Barthin's tumors and something funny. And when we repeated, it was actually a TB granuloma. So if I find a definitive evidence of TB infection which has not been taken care of, which is extremely rare, I would add TB treatment for the second time, but by and large, I treat them with my steroids, immunosuppression, or whatever.
Okay. One question to Dr. Sudarshan, something again very basic. How does the fundus autofluorescence help in detecting disease activity?
Honestly, I'm not very good in imaging, and probably somebody else can take over.
Yes, Dr. Amla, Dr. Vaishali.
For us, autofluorescence is in uveitis tends to occur after the event. The clinical pictures tend to show up disease activity before the autofluorescence. You know how it is. When we are worried about whether we are missing a heredomacular versus inflammatory conditions, yes, that's when the autofluorescence really comes into its own. But for inflammatory conditions, it's a bit late.
It's more for the follow-up, like when you don't want an
you don't want
technique.
you
don't want
kind
an
of
invasive technique. Instead of, if you have during the follow-up, you don't want to repeat FFA again and again, then autofluorescence probably helps.
Okay, thank you. We shall now go on to our next speaker, Dr. Alok Sen. There's echo coming. Who's a senior consultant UVEA and Vitreoretina from Sadguru Netra Chikitsalaya Chitrakoot from Madhya Pradesh, and he's going to talk on 5 challenges in uveitis management. On to you, Dr. Alok.
Am I audible and my slides are visible?
Yeah. Yes.
Yeah. Thank you. Thank you so much for the opportunity, Chitra ma'am and Partho sir. So I will be in next few slides, I will be showing some cases which are like lesson learned for me, and probably this will help for general ophthalmologist and budding UVEA specialist, that how over the years I have learned from some of my cases. So my first case is a 48-year-old male who presented to us with progressive blurring of vision for 6 months, and he had history of night blindness. He was a known case of diabetes, and the vision in both eyes was 6/9. However, he had mild vitritis in both eyes. The fundus apparently looked normal to us at presentation. The FFA although showed diffuse leakage from the vessels and the capillaries. We did a baseline uveitis examination, and which showed a negative VDRL. HIV was also non-reactive. MON2 was positive. So considering it to be an idiopathic, thinking it to be an idiopathic vasculitis, we started the patient on oral steroids. However, the patient worsened with oral steroids, and on follow-up, although the fundus was essentially the same, what we found was there was stippled hypo-autofluorescence on FAF and OCT, which showed typical RP nodularity. And so we thought that we could have been dealing with syphilitic chorioretinitis, and we repeated the test, and this time both the TPHA and VDRL came positive, and we started the patient on IV ceftriaxone, following which the patient had resolution of the RP nodularity and improvement in vision. So my first lesson was that VDRL itself can be falsely negative in up to 30% of the cases, and both TPHA and VDRL should be ordered for screening of these patients. My second case is a 50-year-old diabetic female who presented to us with loss of vision in the left eye for 2 weeks. And she gave history of burning, micturition, and fever 1 month back, for which she was treated elsewhere. And on examination, she had anterior segment cells and dense vitritis obscuring fundus view. And you can see the B scan showed diffuse dot-like echoes with loculations suggestive of endophthalmitis. So we made a provisional diagnosis of endogenous endophthalmitis, and we did a diagnostic vitrectomy and gave intravitreal vancomycin plus DEXA. and send the vitreous biopsy for culture. This was 3 days post vitrectomy. There was improvement in media clarity. The vision had improved to 660. What you can see here, there were few patches of retinitis, which can be appreciated. We thought that we were dealing with endophthalmitis till now, and we continued the patient on steroid. To our surprise, there was progression of retinitis within 3 days, rapid progression. So we thought that we might be dealing with viral retinitis, and we stopped the steroids and put the patient on valacyclovir. And this is following 4 weeks of treatment with valacyclovir. You can see that the retinitis had resolved. The vision had improved to 618. So sometimes ARN can be misdiagnosed as endogenous endophthalmitis, and steroids can lead to rapid worsening of the condition. Third case is a case, and this was partly discussed in the previously in the presentation of vasculitis. This patient presented again a diabetic 50-year-old female who presented to us with multifocal retinitis following a episode of fever which was 20 days back and was diagnosed as typhoid. So we made a diagnosis of post-fever retinitis, and we started the patient on oral prednisolone and doxycycline. Following treatment, there was some improvement in the left eye. However, the right eye showed progression, and the left eye also showed an evidence of neovascularization over the disc, as you can see here on the FFA. So in the left eye, we gave intravitreal anti-VEGF along with steroids, following which there was improvement in the left eye, and the retinitis also resolved. Having seeing a good response in the left eye, we decided to give an intravitreal steroid and anti-VEGF in the right eye as well. However, after 4 weeks, the patient presented with a fulminant retinitis in the inferior quadrant, and we thought that this could be toxoplasmosis secondary to intravitreal steroids. So we took up this patient for pars plana vitrectomy to remove the residual triamcinolone and gave intravitreal clindamycin and started the patient on Septran DS. And after 4 weeks, there was resolution of retinitis, and the patient retina remained attached. So reactivation of toxoplasmosis retinitis can occur after IV intravitreal steroids, and particularly in retinitis, one should avoid giving intravitreal steroids. My fourth case is a 30-year-old male who presented to us with the redness in the left eye and pain and redness in the left eye. He had a history of similar complaints in both the eyes for past several years and was treated topically as well as oral medications. The details were not known. He had a history of inguinal lymphadenopathy 1 year back. The uveitis exam investigation showed a positive MON2, and both VDRL and TPHA were positive. And fundus examination showed these multifocal patches of retinitis along with the vasocentric or subvascular healed choroiditis lesion with tortuosity of vessel and sheathing, which was very suggestive of TB. However, because both VDRL and TPHA was positive and there was multifocal retinitis, we treated the patient as syphilis, and after 14 days of treatment, there was resolution of the retinitis patch. However, after 4 weeks, the patient presented with a juxtapapillary chororetinitis, and which soon progressed, and there was increased edema with progression of the chororetinitis. So we thought that this could be a tubercular lesion, and we started the patient on steroids and AKT, and this is after treatment with steroid, there was resolution of the lesion. So one must keep in mind that some of these patients can have co-infections as well, especially if they are immunosuppressed. My last case is a 13-year-old female who presented with bilateral pain and redness, and she had an anterior segment reaction of 1+ and vitritis, and she presented with bilateral disc edema. The OCT at presentation, except for disc edema, appeared to us to be normal. We did a basic uveitis profile, which was negative. Neuroimaging was within normal limit. So we thought that this could be an intermediate uveitis or pan-uveitis, which was causing disc edema. We started the patient on oral steroids. The patient in next 5 months had 3 recurrences of anterior segment inflammation. on tapering the steroids to less than 15 milligram. And so we also put the patient on methotrexate, 15 milligram per week. And after 4 weeks, the patient presented with multifocal plecoid cream-colored lesion, choroidal lesions in both the eyes with a neurosensory detachment. And the ICGA showed typical hypocyanism dark dots, which we associate with a VKH. And even the OCT was very characteristic of VKH. So the patient was treated with IV steroids and immunosuppressive agent. And this is the current picture. The patient has has little bit of edema. However, what we missed out on the diagnosis was probably because we did do angiography at the baseline. So to summarize, both VDRL and TPHA need to be done for screening of syphilis. ARN can sometimes mimic endogenous endophthalmitis, and you have to keep that in mind. Intravitreal steroid should be avoided or be used very cautiously in patients with retinitis. Keep in mind co-infection, especially in immunosuppressive agents. And it is important to get baseline imaging in any patient with posterior segment inflammation. Thank you so much. And I would like to thank Professor Gupta here, who has been guiding us for our department in improving our uveitis management. Thank you so much.
Thank you so much. That was a absolutely wonderful presentation and so many interesting cases of diverse managements. Really thankful. So I'm going to go back to Dr. Sudarshan and ask this question. Supposing you have a patient with mature complicated cataract, would you always wait for the disease remission, or would you also suggest that go ahead and do the cataract surgery under steroid cover?
If it's ideally, we'll have to wait for the inflammation-free period of 2 to 3 months. But these kind of intumescent cataract and situations where, waiting for the cataract surgery, deferring the cataract surgery, which is going to cause more harm, then probably you can plan up cataract surgery. And if the posterior segment, if you're very sure it's a non-infectious uveitis, maybe you can plan Ozurdex or perioperative steroid cover. But ideal situation is to have it under control for a few months and then only operate.
Dr. Partho, Dr. Srinivas?
I have a question to, I think I'll first go to Dr. Rohan Chawla and then I'll go to Professor Gupta. So the vitreous is a dangerous confounder, as Dr. Alok has shown in one of the case. However, I'm not very sure that whether it was an acute retinal necrosis or not, because the lesions were not characteristic or so anyway. So vitreous is a dangerous confounder, and it can actually create confusion between panuveitis and endogenous endophthalmitis. And I remember seeing a case which was treated elsewhere. A case of ARN was treated thinking it as a Behçet disease because the patient gave a history of oral ulcer, and it was a very very pathetic condition because the patient presented with PL negative vision. So Dr. Rohan, any tips to differentiate between such conditions like between the panuveitis and the endogenous endophthalmitis?
Yeah, you see, so you see that ARN sometimes, if you allow the disease to progress, will cause a lot of vitritis, and then there might be a confusion in diagnosis. So whenever you have such amount of vitritis, you should try to do a very careful fundus examination. Sometimes, even if you can see the temporal periphery, you might get those patches, those white patches of viral retinitis, and which will help you clinch the diagnosis. So try to see any little bit part of the fundus as possible. That might give you a clue. Try to see the other eye. That might be the clue. And before making a diagnosis of metastatic endophthalmitis, you should also have some sort of a clinical profile of the patient. Is the patient prone to metastatic endophthalmitis? Is there any source of infection, or any recent, or maybe even a month or two, and history of any IV antibiotics or any IV infusion given which might predispose the patient to endogenous endophthalmitis? So unless you have some predisposing factors or some immunosuppressive state, maybe an uncontrolled diabetes even, they only then consider endogenous endophthalmitis. Otherwise, It can be ARN, it can be a very severe pars planitis also. So you have to look at the clinical scenario and try to get a look at the fundus as far as possible in either eye, which also can give you a clue. And sometimes then the look of the vitreous, if it is a yellowish or exudative look, or even there is the pattern of the iris doesn't look good, some exudation in the anterior chamber itself, then maybe those are again pointers towards the endophthalmitis.
Actually, ma'am, like some condition where you can't see anything, severe vitreous haze. So how to proceed, means?
I think what Rohan has already said. In addition, one has to remember that uveitis may be very severe, but it never produces yellow glow. So if you are seeing a yellow glow, it means it's more likely to be endophthalmitis than very severe panuveitis. And as far as I'm concerned, I do a lot of vitrectomies for diagnostic, for therapeutics, and even in severe intermediate uveitis and panuveitis, my vitrectomy is before immunosuppression. So I'm very comfortable taking these patients to OR, taking the sample, doing the complete clearing, and getting the diagnostics, my flow, molecular, and now omics, of course. So to find the answer through the vitrectomy. But then everybody doesn't do it, and I'm not recommending it, but that's what I follow.
So yellow glow and sometimes vitrectomy can help.
Yeah, if you cannot decide, just go in and clear the vitreous. It really reduces the need for steroids and immunosuppression, because that vitreous is kind of harboring a lot of chemicals, interleukins and all. And the amount of the dose that you need to reach there to take care of them reduces dramatically once you have removed the reservoir of all these mediators. So vitrectomy is basically diagnostic, but it also helps a lot in the therapy.
Dr. Amit, you want to add anything?
So I can only tell my experience where I got stuck. If you have a subretinal fluid, you think there was a fungal infection which came in, so doing an ultrasound choroidal thickening will add to it. I have this dilemma: should I give an intravitreal injection and have a doubt of infection? So if I have a vitritis, I might give an intravitreal injection to see how the response is and get a tap and get an idea if I am in a dilemma. I had one dilemma in a patient of psoriatic bilateral uveitis. So sometimes the tap may be negative. Then you do, if you have a doubt, go in for a vitrectomy.
Shall we go on to the next speaker, Partho?
I just want to make a point.
Yes, Sudarshan.
I mean, like, first of all, Alok's talk was wonderful. Ultimate good talk. Basically, like, one or two things about this co-infection one. It's not always very helpful, but we actually had a series of patients where we did aqueous tap in patients with suspected syphilis, which had titers raised in the blood. So where probably in such a situation where he had one patient which had probably both syphilis and tuberculosis, possibly, an aqueous tap of raised RPR or TPH titers in the aqueous sometimes helps a diagnosis of an ocular syphilis. So even juxtapapillary Corroditis is the initial description of syphilis, called Jensen's Corroditis. Like, that was the initial presentation of syphilis. So when you show, even the follow-up probably would have been syphilis itself. You don't know, because it is healed with the steroids. Immunosuppressed patients, actually, after the penicillin course, the infectious disease specialists here continue on Doxy for a long time. So that actually helps prevent recurrences. If you've had patients who have had on cephalosporins, and they are known to have recurrences more than patients who have had treated with the penicillin. So if a patient is not on penicillin, then you probably need to continue doxycycline for a long time.
Thank you.
Very good.
Thank you, sir.
Yeah.
Thank you.
Very nice cases, Dr. Alok. It was a warm-up session for all of us before USI meeting.
Yeah.
Thank you. Thank you.
Very nice. Very nice way of presenting also. Very good.
Very nice. We shall now go on to our next speaker, Dr. Swapnil Madhukar Parchan, who is a consultant vitreoretina and UVEA services from MGMI Hospital Institute, Raipur. And he is going to talk on CMV retinitis, the 5 challenges. On to you, Dr. Swapnil.
Thank you so much, ma'am. And thank you, Partho sir, for giving me this opportunity. Can you see my slides?
Yes.
Yeah. So I'll directly go on to the challenges. So first challenge in CMV retinitis, it's to diagnose the case. So CMV retinitis is basically a clinical diagnosis. So basically you see full thickness retinal necrosis. So there is a lot of retinal necrosis with overlying retinal hemorrhages. Usually they are seen over the posterior pole or mid periphery. And this appearance is called as pizza pie appearance. It is also called as fulminant or edematous type. So next variety is indolent variety, where you see this granular appearance of retinitis and adjoining some healed retinitis patches. So if you see that there are most commonly 4 causes of retinitis. So if you want to distinguish, as I told, CMV retinitis, there is minimal or of vitreous inflammation. There is retinal necrosis with overlying retinal hemorrhages, which is mostly in the posterior pole or mid periphery with associated retinal vasculitis. If you see acute retinal necrosis, there is significant vitritis. The retinal necrosis starts in the periphery. They are tongue-shaped lesions. They spread circumferentially and then they go on to move to the center. Coming to progressive outer retinal necrosis, it is the outer retina that is involved, and it is basically described as cracked mud appearance. And last differential is toxoplasma. So it is head-like in fog appearance. Usually you see this retinitis lesion with overlying vitritis, and there might be associated adjoining pigmented scar. So a challenge to, once you diagnose a patient with CMV retinitis, how should you treat it? So there are various drugs available for CMV retinitis. So first and most important, all these drugs are virostatic rather than virostidal. Most commonly used drugs for treatment of CMV retinitis in Indian setting is gangcyclovir, which can be given intravenous or intravitreal. And another drug is valganciclovir, which is given oral. Most challenging thing in treatment is the cost involved in treating this patient. Most of these patients are from low socioeconomic background, and they usually take this treatment for ART center, which doesn't have smooth supply of this drug. So most of the patients are defaulters when we are treating these patients with for CMV retinitis. Third drug which is used in treatment is foscarnet. The foscarnet is considered a better drug as compared to gangcyclovir, since it acts against both DNA polymerase of CMV as well as reverse transcriptase of HIV. And studies have shown that patients who are treated with foscarnet has a longer life expectancy as compared to patients treated with gangcyclovir. But unfortunately, in India, we don't have supply of foscarnet. And lastly, we have cidofovir. It is mostly reserved for patients who do not respond well to gangcyclovir or valganciclovir. So how do we treat? So mostly for zone 1 disease, which is considered the disease which is involving the macular area or adjoining the optic disc. For zone 1 disease, we usually give systemic valganciclovir or systemic gangcyclovir along with intravitreal gangcyclovir. Whereas zone 2 or zone 3, which is involving the peripheral part of the retina or mid periphery, it can be just treated with systemic valganciclovir. The third challenge is how long we need to continue antiviral treatment. So for patients who are HIV, we have guidelines when we need to stop the treatment. For stopping the treatment, the patient should satisfy 3 criteria. First is he should be compliant with heart therapy for at least 18 months. Second is there should be a documented CD4 count of more than 100 for at least 3 months. And retinitis lesion should be quiescent with prolonged relapse-free interval. So this is regarding HIV. When we come to non-HIV patients, like patients who are organ transplant patient or patients who have blood cell dysplasia, so the treatment protocol remains the same, but important thing is there is no clear-cut guidelines when we need to stop anti-CMV therapy. Various publications have shown that there is high chance of recurrence to the extent of 33 to 44% once after discontinuation of anti-CMV therapy. So the guidelines are the maintenance phase should be continued till there is signs of immune recovery. And this can be achieved either by stopping or decreasing the dose of immunosuppression. But again, this has to be done in consultation with the primary physician. And there should be a reliable sign of CMV inactivity. That is, there is resolution of CMV retinitis with subsequent atrophy. So in this image, we can see that there is active CMV retinitis, and once it heals, it is healing with pigmentary changes and scarring. Fourth challenge is, once this CMV retinitis heals, so retina becomes atrophic. So they have tendency to develop large breaks, which are multiple in periphery and surrounded by the atrophic retina. So what are the difficulties while managing this patient who develop retinal detachment post CMV retinitis? First is induction of PVD, because vitreous mostly near to the retina are infiltrated with the inflammatory cells, and this vitreous is densely adherent to the inner retinal layers. So once you try to remove the hyaloid from this atrophic area, there is tendency of formation of breaks. So in such cases, it is advisable that rather than pulling the hyaloid, you should rather trim the vitreous nicely. Second difficulty is there are multiple and large breaks. So it may not be possible to laser break 360 degree in isolation. Rather, you might have to laser it. You might have to do it like a barrage laser, which is isolating the atrophic area from the normal healthy retina. And third is, what type of tamponade should you use? Whether you should use 1000 centistroke oil or 5000 centistroke oil. Mostly these patients require long-term tamponade. So most of the cases, like one-eyed patient or pediatric patient or patients with bilateral retinal detachment, long-term tamponade with 5000 centistroke oil is advisable. Then comes the role of belt buckle. The role of belt buckle is controversial, but if you see the advantage, belt buckle usually relieve the residual traction that is present at the vitreous base. Most of these patients are phakic, and you may not be able to remove the vitreous from the vitreous base completely. So it can support the vitreous base in such cases. Secondly, the inferior necrotic retina may not be adequately tamponade because of Boyne's effect of the oil. So this buckle or belt might support this peripheral inferior part of the retina. And third is, in heart era, the life expectancy of the patients with HIV having this CMV has increased. So once after oil removal, this belt can provide a long-term equatorial support and takes care of PVR. But disadvantage of belt buckle is that it can cause inadvertent needle prick to the surgeon or assistant. The fifth challenge is number of procedure following CMV RD repair. So this is the publication from PGI while I was a resident. So this table shows the patients who were operated for RD post CMV in pre-heart era and heart era. So if you see the mean follow-up area, follow-up is 16 months in pre-heart area, whereas it was 41 months in heart area. Almost 11 of 12 patients lost follow-up, whereas only 3 patients lost follow-up out of 16. So this tells us that the life expectancy of this patient have increased. But if you see the additional procedure underwent by patients who were operated in heart era, it is around 29. So they underwent cataract surgery, BSK removal, silicone oil removal, and capsulotomy. So number of procedure post RD surgery has significantly increased. So when should we remove the oil, or whether we need to keep oil lifelong? So if you see the various studies which have documented the redetachment rate, it is in the range of 18 to 53%. And they have published that almost in 18 to 31% of the eyes, oil can be removed. But prerequisite for oil removal should be attached retina. There should be absence of unlasered break, and there should be absence of hypotony. So if these 3 criteria are satisfied, then one can try removing the oil in such cases. Thank you so much for your patient.
Thank you, doctor. Thank you for such a thorough talk and very well covered. I'm going to again start off asking a very basic question. Do I ask Dr. Rohit? I'll ask this question. What could you see as the advantage of oral valganciclovir to ganciclovir?
Dr. Rohan Newman.
Yeah, is it you're asking me?
Yeah.
Okay. So see, oral definitely it's a systemic therapy. It will help in bilateral disease, and intravitreal injections have to be given very frequently. So even if we give the high dose regime with around 6 milligram, then also we have to give it twice a week. So like he had already presented, if the disease is severe, it's in zone 1, then you need to do both. You have to complement it and give as much therapy as possible. But if the disease is in zone 2, and especially if it is bilateral disease, then oral valganciclovir, if the patient can afford, is today the therapy of choice. Of course, along with heart.
Dr. Partha?
Yeah, no, every time I just keep asking that. I'll repeat the same question because the audience should actually go with a clear message that how relevant is the torch titer in such viral retinitis?
Absolutely non-relevant.
Exactly. So it's basically these are all ubiquitous organisms. There's no point on relying on the serological test for that.
Yeah, I totally agree. It is meaningless. Torch serology is meaningless in viral retinitis.
Okay. So, Dr. Sudarshan, how to differentiate the CMV in immunosuppressed patient due to immunosuppressed, like taking immunosuppressive drug, and CMV in HIV patients? Is there any difference in approaching these cases?
Can you hear?
Yes, yes.
Difference in the diagnosis sometimes is little difficult. I mean, basically, you can have some amount of inflammatory response in non-HIV patients. In HIV patients with low CD4 counts, I mean, that's what was the initial description. In HIV patients with low CD4 counts, CMV is usually present. But if your counts are better, or if in non-HIV immunosuppressed, sometimes you can they can present with retinitis, vitritis, and some vasculitis also. So an aggressive form of therapy with significant inflammatory response is seen in non-HIV CMV retinitis, organ transplant, or otherwise immunosuppressed. So HIV is a sustained immunosuppression. Approach-wise, as Rohan was just telling, that the ganciclovir is the treatment for CMV retinitis, but in HIV, ART is the treatment for the cause which caused the immunosuppression. So you need to make sure that you are following up the viral load and CD4 counts in a non-HIV, I mean in a HIV patient, and DRT has to be continued along with ganciclovir. In non-HIV organ transplant, once we cannot stop the immunosuppression, for instance, with a renal transplant, so you modify the drug dosage, and sometimes the systemic therapy for CMV in non-HIV, like renal transplants, cannot be given because of the kidney toxicity. So you rely more on the intravitreal therapy in renal transplant patients because of the reason that the dosage of valganciclovir needs to be much lesser. See, we used to be initially doing something called PP65 antigenemia testing in when to stop this therapy in non-HIV patients. But then now it's no longer considered that relevant. They tend to do the blood PCR values and the intraocular specimen PCR values sometimes to decide the viral copies and titrate the treatment.
Anything else to ask, Dr. Pathur? We go on to our next speaker.
We can go.
Yeah, we have our next speaker, Dr. Ankush Kawali, who's again a uveitis from Narayan Netralia, Bangalore, and he's going to talk on 5 challenges in retinitis.
Thank you. Are my slides visible?
Yeah, yeah.
All right. So I'll be talking on 5 challenges in retinitis. Well, when the morphological presentation is like this, when it is classical, there are no challenges. What I'm going to discuss about the cases, 5 cases which had atypical presentation or delayed presentation, or they had complications. So my first challenge, 53-year-old lady, she comes with a large granulomatous diffuse pigmented capes, and because of which the media was very hazy, through this hazy media, we were able to make out patches of retinitis in the far periphery. So the diagnosis, left eye granulomatous panuveitis. The first differential comes to our mind is ARN. The baseline workup was negative. The patient was started on injection acyclovir, followed by oral along with steroids. Well, after a week, there was mild improvement in the KPs. Now the media was slightly clear, and what we saw was a diffuse retinitis in far periphery. The patient had sclerosed vessels, and the retinitis was rapidly progressing towards the macula, along with satellite lesion. Well, so what we are dealing with, the patient is not responding well, her vision is still 660. So either the virus is not responded to the given treatment, or it is not virus. Patient not responded to ganciclovir as well. Moreover, the PCR test for HSV vis-a-vis all came negative. The very second differential diagnosis comes to mind in this case, which is not responding to the antivirals, is toxo. And fortunately, the PCR came positive, as well as the patient tested positive for serology as well. So after switching over to the anti-toxo treatment, there was a dramatic response. So as you can see, the entire patch of retinitis slowly scarring, and it is all resolved. After 2 months, the patient came back with a rheumatogenic RD. So the challenge in this case is that although the presentation and the course of the disease is typical of ARN, the cause was toxoplasma. Coming to challenge 2. Now this patient, as you can see here, there are slightly atypical scars along the vessels. There is a sclerosed vessel and a strange scar, conical scar coming from periphery in the right eye. This patient had vitritis and she had positive MAN2. Quantiferon tested negative. The patient was empirically started on ATD. She took for a month. After that, she stopped. She got pregnant, and after several months, she comes back with this kind of retinitis patch in her right eye. And now the anti-chamber tap comes positive for HSV genome. After starting the antivirals, the patch resolves. Now, if you look at the anterior segment of this patient, patient has got these peculiar iris atrophic changes, which are more characteristic of a viral disease rather than tuberculosis. The same iris atrophic changes can be seen in her left eye as well. She had recurrence in her left eye, and the same organism was isolated from the left eye as well. The patient is on a long-term antiviral treatment, and with that, inflammation is under control. There is no recurrence of vasculitis or any Corroditis. So the challenge in this case is our limited knowledge of varied presentation of viral uveitis. Well, one can argue saying that the patient had tuberculosis earlier, which was presented as a sclerosed vessels and scars along the vessels, and over that the patient had HSV. But looking at the anti-segment changes as well as the conical lesion what I showed in the right eye, I feel it's more towards the viral etiology rather than tuberculosis. Coming to challenge 3, a 42-year-old male, he had non-granular anti-uveitis presented with just 2+ cells as vitritis and this kind of perivascular scar. Macular edema. Now looking at the scar, one would think about toxo and TB, but workup was negative for both. The patient responded to oral steroids. The inflammation came under control. But after stopping the steroids, after 2 months, the patient presents with hypopyon. And along with that, you can see the multifocal retinal lesions in his left eye. So obviously, we'll think about one disease which comes with occasional oral ulcers. The patient tested positive for HLA-B51. And yeah, so challenge in this case is a delayed typical presentation. Not always we have been taught that the Behçet disease presents with hypopyon, multifocal retinitis patches, but sometimes this typical presentation can be delayed by several months. Coming to challenge 4, here is a 52-year-old male. He was treated elsewhere. His vision was hand movement in the right eye and counting finger in the left eye. He had festoon pupil, KPs, and he tested positive for R effector. MAN2 was positive, TPHA was negative. He was initially started on steroids, followed by ATT as the response was not good. And at the presentation to us, he was already on ATT 1.5 months. If you look at the OCT scan, there is a retinal involvement, mild retinal thinning. There is a ERM. And if you look at the OCT scan over those yellow lesions, they are subretinal. So the vision in the right eye has not improved, whereas left eye has improved. Now, 3 things come to mind looking at this clinical picture. Masquerades, could be lymphoma or enthaporan toxicity because the patient is already on ATT, the right eye vision is not improving, or it could be case of resolving epidemic retinitis. So first and foremost, stop the ATT and see whether the patient's visual acuity improves. Well, after a month, the right eye is still counting finger. So what you do? To rule out masquerade, we have to advise PET scan or consider the vitreous biopsy or choroidal biopsy. But before that, a simple test, since the epidemic retinitis is our third differential diagnosis, you can advise Bilflix test, which came positive, and patient responded to the doxycycline. In 6 days, his vision was 6/18. Repeated Bilflix after 3 months comes negative. So this kind of presentation, the yellow spots, we do see in case of epidemic retinitis, also called posterior retinitis, when there's a serous detachment, and once the detachment resolves, this kind of yellowish lesions subretinal can be appreciated in a case of resolving or resolved epidemic retinitis. So one will say that the talk is on retinitis, but there's no retinitis. If you look at the OCT scan, there is a full thickness involvement along with mild thinning. Probably the patient had retinitis 2 months back, which has resolved. Then we had these complications. So challenge in this case is identify the sequelae of uveitis. Now coming to my last case, a student, 21-year-old, had a history of booster dose. 1 month ago, he is a known case of psoriasis, and he has those cortical spots. He was diagnosed and referred as epidemic retinitis or SLE. Now you look at the, and he had a subretinal fluid, but there is no significant retinitis. The vitreous was pretty clear. Now, if you look at the choroid here in the mid periphery, there are some lesions. So before you jump into any investigation in this case, the presence of cortical spot, better to check the BP first before you consider any other lab investigation. And in this case, surprisingly, in 21-year-old, the BP was 200/130. And this was the kidney parameters. His creatinine is high, blood urea was high, ANA profile was negative, TPH was normal. So this is basically a hypertensive chororetinopathy which mimicked uveitis. So the challenge in this case, misguiding history, psoriasis, and booster dose of Covishield, identify masquerades which could be not only neoplastic, but also it could be non-neoplastic. So keep at least 2 differentials when you see a case of uveitis. If the first treatment is not working, consider the second differential. Accordingly, you modify your treatment. To constantly update your knowledge of uveitis, be aware of overlapping uveitis. The patient can have 2 different uveitic conditions. Patient can have 2 different infections as well. Typical findings may manifest during the course of the disease. The patient may not come to you with all classical findings at first visit, but he might develop it later on. And know the signs of resolving or resolved uveitis, and be aware of masquerades, not only neoplastic but non-neoplastic. Thank you.
Thank you. Very nice talk. I mean, one better than the other. Very nice. I would take one question with you, Dr. Vishali.
Dr. Chitra, your voice is echoing a lot.
Mr. Sunil, everybody's voice is echoing in the discussion. Shall I ask my question? When would you start oral steroids and acute necrosis, and when you do tapering?
The question is steroids in acute retinal necrosis. Is that right?
Yeah. When do you start?
I think it should always be under the cover of antiviral agents. So you are never in a hurry to start steroids. First, you've got to give cover with antiviral agents. And even when you are giving steroids, you should know that the purpose is not to immunosuppress the patient. So high-dose steroids are not required. In acute retinal necrosis, you are toxoplasmosis for that matter. You are using steroids as anti-inflammatory therapy. So you have to go low on the dose. And the second thing is never ever inject local, because the systemic, if you are giving and you are in doubt, you can stop it and taper it off. But once you have given in the eye, that can be very dicey. So that's how, and the steroids should be tapered fast. The long-term steroids have no role because, as I said, they are anti-inflammatory and not for immunosuppression. So you don't need them on the long-term basis.
Thank you. Thank you. Dr. Partha?
Yeah. So it is said that the retinitis is almost always infectious, except for primarily two conditions. One is Behçet disease and another is intraocular lymphoma. So Ratina ma'am, can you give us some tips to diagnose Behçet disease? Means what are the features one should look for?
One should look for which disease? Behçet's.
Behçet.
Yeah. Yeah, in Behçet's, one thing, definitely mouth ulcer. You have to ask every visit and you have to tell them maybe mouth ulcer not at the time of presentation, maybe years back. Because sometimes they say that 2 years back I had recurrent mouth ulcer. Every month I will have ulcer. Now it is better. So in Behçet's, symptoms are spread over long time. So we have to ask past history of mouth ulcer or genital ulcer. And one practical question, practical point is, once we talk about genital ulcer, they always think of STD, sexually transmitted disease. So what I do is, there is allergic disease that causes ulcer as well, ulcer in mouth as well as in genital area. I suspect that disease. Do you have genital ulcer? Then they are open. They say that they had genital ulcer. And joint pain also need not come at the time of UVEA test. It would have happened a year back or 2 years back. And erythema patches occasionally. So systemic history may be spread over time, that we have to really specifically ask those things regarding the time duration and all. Then ocular thing. It is always non-granular matters and many times with hypopyon and always fern type vasculitis in FFA. And if it is a chronic case, pale disc. Occlusive vasculitis with pale disc. As I already mentioned, neovascularization is very rare when you compare with Eels. So these are all the differences and salient features of Behçet's.
Thank you.
Behçet's is always chronic and recurrent.
Is there any other question one of the expert panel would want to bring out in this very important talk? Anything else we are missing out in the discussion in the last few talks?
Rohan, you want to highlight anything?
Well, very nice cases, Dr. Ankush. I just wrote to him also, especially his case 4, probably I would have missed the epidemic retinitis there. I might not have suspected it, but probably like the way he treated and that such a good response does show that there was an element of some infection which responded to doxycycline. And the other thing I wanted to highlight from his cases is like he has shown that those focal corroditis patches under the vessels, I think they are not very specific for TB and we should not give too much of importance to them and just start ATT just if we see those spots. You see, I think it's just a spillover inflammation. Even a vasculitis which is very severe, it can spill over. There is a continuum of tissue. It's not just that the inflammation is going to lie only in the vessel. So sometimes it may spill over into the retina and go down to the choroid or at the level of the RP and you will get those scarring. It's not just that those and like he has shown in those cases, they were not tubercular. And I can show you n number of cases which were not tubercular but have those findings. So not just one finding should lead you to TB. It should be a combination of findings.
Okay.
Yes. Partha, anything else to ask before we go to our next speaker? We do have time actually.
How long? I want to ask Ankush, how long do we need to give Doxy?
Well, we give Doxy in these cases at least for 3 weeks, 2 to 3 weeks, I will say. Yeah.
100 BD, is it?
But so I generally start after during the investigation itself. So I advise the patient investigation and start the Doxy immediately. So that after 5 days, when I see them, I see the response to the given treatment. If I see the response is not adequate, those retinitis patches are not coming down, or say the macula is not coming, macular edema is not coming down, then I start thinking about different differentials like say hypertensive or masquerades or SLE?
Because we generally in other infective or infection related hypersensitivity, we say like we need to stop steroids and then continue antibiotics and then stop. So, but this is a little different, I guess. No, like it is not necessary that you'll have to continue doxy after the steroid course.
Yeah, so initially when I was treating those cases, I used to give only steroids, thinking that just the immune reaction to the fever because the patient has presented to us and patient gives history of the fever has been gone 2 weeks back or 1 month back. So initially I used to give only steroids, but I had a few cases in which the second space they resolved steroid, but they came back again, a kind of mild retinitis, and patients were not that happy with the steroids. Then I started combining with this doxycycline. The response was very good. Then I did a study in which I compared the patients who received only doxycycline and doxycycline with steroids, and I found equal results. So then I thought, why should we use steroid at all? So in past at least more than 2 years, I'm giving only doxycycline without any steroids, maybe with topical steroids or topical NSAIDs, and results are equally good.
So, Ankush, one of the major complication in this viral retinitis is the optic nerve involvement. Many of the time we'll see the viral retinitis has resolved, the optic disc is pale. So, how to address the
Surprisingly, for this particular entity, I have not seen much of optic neuritis as we see in cases of ARA now. So, optic neuritis, when it comes, yes, of course, I think we have to combine them with steroids. But I will say, in my experience for this disease, the optic neuritis incidence is maybe less than 5% or maybe less than that.
No, I'm not talking about the optic neuritis. I'm talking about this. Many of these viruses are neurotropic virus, so they involve the optic nerve quite often. So that's what I was thinking, that whether in such any signs to look for, maybe the peripapillary subretinal fluid accumulation or anything, or whether we need to hike up the.
Yeah, so for that, I did another study in which I studied the HFA, visual fields, whether I'm missing some optic nerve involvement or not in such cases. So in this also, I compared one group who received steroid and one group who did not receive any steroid. And there was no much of difference as compared to the other group. Both of them had equal amount of visual field defects. So I really don't think whether adding steroid, we are going to achieve something more.
Okay, point well taken. Okay,
Yeah,
go to the next.
We shall now go on to our next speaker, Dr. Bikramjit Pal from Ranchi, who's again from the Retina Care Center at Jharkhand. And he was going to talk to us about the 5 challenges in masquerade syndrome.
Very good evening. My slides are visible?
Yeah.
So thank you, Dr. Partho and Dr. Chitra ma'am, for having me on this platform and to share my experiences on masquerade. Close friend Dr. Vishal, who has helped me with this topic, as masquerade is really a very rare occurrences and we don't see these very often every day. So how to go about it, I just had a brief discussion, so I would definitely like to acknowledge him on that. So by definition, malignant, if you see masquerade syndrome, so it's basically a malignant or a non-malignant conditions which generally mimic the inflammatory.
I'm sorry to interrupt. Your voice is not very clear.
Is it clear now?
Yeah. Can you just come near to your desktop or from where you are present?
Yeah, is it clear now?
Yeah.
Yeah, now it's better.
So it's any malignant or non-malignant conditions which mimic an inflammatory or a uveitic condition. It was first introduced by Theodore in 1967. So there's also something called as reverse masquerade, in which there is inflammatory ocular conditions which mimics neoplastic conditions. So I'll go by 5 challenges, and under each challenge I'll talk about few cases, and at the end of each challenge I'll say some silent points or takeaway points. So the first challenge of a masquerade is to finally recognize that it is a masquerade. How do we recognize it's a masquerade condition? So the first challenge is the clinical diagnosis. And the first and most common diagnosis that I come across in my practice is a posterior scleritis, which has been referred as a choroidal mass lesion. Is it audible now? Is the voice fine? Hello?
Yes, go ahead.
So the first thing that we come across is a posterior scleritis. So obviously we can do multiple investigation to rule out a choroidal mass, but clinically, if you look, there are very few salient points which tells you that no, it is a posterior scleritis and not definitely a mass. So if you look at the first arrow on the top, you will see some folds. These are choroidal folds which are originating from the disc and going away. So if you are seeing a choroidal mass which are better picked up on FFA, that means there's something which is pressing from outside. And it is not intraocular mass, but something which is pressing from outside. And if you go ahead and do an FFA, obviously you'll see a typical hot disc, which is suggestive of a posterior scleritis, and which can readily be differentiated from a choroidal mass lesions. The second case which we come across is a posterior uveitis, or is it a typical case of a PVRL? Now, PVRL as such, the rarity, the case is not very common, and it's rare when you compare to a posterior uveitis. Although if you look into the picture, sometimes the lesions might look similar. But clinically, if you look at the posterior uveitis, you will definitely see the amoeboid shaped lesions and with the margins which are not very clear. And if you compare these lesions with a typical PVRL case, you cannot, once you see a typical PVRL case, you cannot mistake it for anything other, which typically shows well demarcated yellowish lesions, lot of choroidal leopard skin appearances. So this helps us clinically differentiate between the two. A third very common clinical thing that we come across is a metastasis. So if you look into a metastasis, if you look into the clinically metastatic lesion, you would see 3 points which typically shows that we are dealing something which is not a very benign condition. The first is the surface of the lesion. If you see the surface of the lesion, the surface shows a lot of irregularity, multiple pigment stippling of the lesions. A very important point which majority of the choroidal metastasis shows are small satellite lesions. If you see the bottom picture and also the top right, you'll see small yellowish lesions which are seen very adjacent to the main lesions. So these lesions are easily missed sometimes, because sometimes we are in a dilemma by seeing such a large lesion that we miss this lesion. But if you look very closely, you would see these small lesions, which helps us to say that no, what we are dealing with may not be a simple benign lesion. So basically, if you look towards the takeaway points from the challenge one, which is the clinical entity, it's very important to look at the patient as a whole, not only the eye. The moment he walks into the OPD, you'll see that something is not right with the patient. Maybe he's very frail. He's a loss of weight if you ask him. And history is very important. So if you ask the history, the origin, duration, progress of these complaints, which help you get you somewhere. Another thing which I talked about was the lesion, which is the surface, the margin and the vicinity of the lesion. If you look carefully, will give you help you in localizing the lesion. And once you look into when you do indirect, just quietly put your hand under his chin to look the local lymph nodes. Similarly, it can be put in the preauricular region also. The second and my favorite is the imaging challenge. Sometimes if you look into the lot of lesions, they mimic each other. So the first, which I called, is called a disgruntled twins. If you look these two lesions, they're almost very similar. The left image, you'll see a circular lesion, which is in the posterior pole. The right picture is also showing something, a yellowish lesion in the posterior pole. Looks very similar, which I saw across in a couple of months. One I saw maybe 2-3 months back and another 10-15 days prior. So if you look, so how is this imaging going to help? Obviously, we can do a FFA, ICG, and plethora of investigation, but a simple OCT can help us guide towards the diagnosis. So if you see the first lesion, the choroid is silent, although it's showing an undulation and an elevation, and there is a back shadowing. So this is very suggestive and very typical of a choroidal metastasis. If you see the right picture, the disc is hyperemic, number one, clinically. And if you see the choroid, there are multiple hyperreflective dots which are seen throughout the entire choroidal as well as the retinal surface, as well as intraretinally. And those hyperreflective spots are also seen in the posterior cortical vitreous. So this is more of an inflammatory region, and this suffices it to be a posterior scleritis. So I think OCT is really helpful in sometimes recognizing very early vitritis, which is sometimes not picked up on clinical examination. We might miss those, but OCT definitely picks up, especially the enhanced depth OCT, picks up those posterior cortical vitreous hyperreflective thing. The second mimic, which I also, which we see which I see common and is referred to me, is the melanoma. So this was referred to as a case of a melanotic melanoma. But if you look clinically, there are some very salient points which are telling us that this is not a melanoma. Number one, the top, the left-hand picture, if you see, along the yellowish lesion that you see throughout the posterior pole, you see a lot of powdery lesion which is present in the inferior border of that lesion. So this powdery lesion is definitely you don't see in a melanoma. Melanoma is always a very well demarcated lesions. The second most important thing that you see here is a rim of a subretinal heme which is bordering across the superior boundary. So I am definitely sure that this is not a melanoma. So what it could be? So here I could do a FFN ICG, and what I picked up was 2 lesions which was very suggestive of a polyp. So since there was no SRF, there was no need for anti-VEGF. I just did a focal laser to that leaking spot. And this was, the top right is just a picture maybe after 2 to 3 months, which is showing definitely that this is a PCV and subretinal altered blood, which has gone away with treatment. A third most important thing that I believe is that ultrasound sometimes we don't do ourselves and we leave it to the optometrist or another person who does it, a fellow. But sometimes in these cases where we are suspecting a mass lesion, it's very important that a clinician himself does the ultrasound so that he knows only he knows what he's looking for. And if you see on the right, you will see a typical ultrasound picture which talks about melanoma, and the left side is a metastasis. So ultrasound should be done by the treating physician himself. So as I told, the history is very paramount. And in today's era, I think OCT has a big role to play in overall maybe retinal as well as uveitic entities. So always choose OCT if its lesions are sometimes less thicker, less than 3 mm. USG obviously if it's more. And whenever we are ordering MRI, brain on orbit or anything, it's better always to send the message across the radiologist that what we are suspecting, so that he will also take much better pictures and better thinner slices to get a diagnosis. And most important, in the era of PET scan and high diagnostic lesions, high diagnostic investigations, there is still role of USG abdomen or pelvis or a chest X-ray, which are humble investigations, but which can help us diagnose, especially on those patients who are poor and cannot afford a PET scan. So a third diagnosis, which is the most important thing, is that a delay. So the first and foremost is, as we know, it's a PVRL. So PVRL, as we all know, it's called a great masquerade. So this is a patient which I saw almost 1.5 to 2 years back. So when he was referred to us, he had already been put on oral steroids and treated as uveitis and posterior uveitis. So when he came, he had typical perivascular, what we call a sheathing in the top left, the middle, and the right. And the right picture, if you see temporary, there is some atrophic patch. So it struck to me, maybe it's a posterior uveitis. He had already been investigated. So he was already started on steroids, and the moment he was started on steroids, he used to get better and he used to recur whenever the steroids were stopped. So on follow-up, typically this he got after a gap of 8 to 9 months between the first presentation and this presentation. He had this typical subretinal yellowish lesion, typical leopard spot appearance, which was pathognomic of PVRL. And I didn't need any more diagnosis to know that this is PVRL. He underwent treatment later on for intravitreal rituximab. Second case which I'll talk about is that we see quite often, which are very much delayed, is a Coach disease. So this is another child who first came to me with no complaints at all and was referred by a treating physician because he thought he saw some yellowish lesions. So if you see in the inferior arcade, there's some yellowish hard exudate. The periphery shows some telangiectatic vessels. So at this point of time, I had told the parents that he might need lesion and this is most probably a Coach disease. But since his vision was good, the parents denied the treatment, and the same child is this seen after 4 to 5 months, which he had exudative artery, extensive questionable perception of light, extensive subretinal echoes. So delay of diagnosis is a very important condition that we come across and which we need to get over with. So if you look typical, and sometimes if you see the previous picture, sometimes it can be confused with retinoblastoma, advanced retinoblastoma. But the retinoblastoma will never show these telangiectatic vessels, which typically seen in Coats disease, end-stage Coats disease. If you see a telangiectatic vessels, it's always a Coats disease. So PVRL is very notorious for waxing and waning coats, which typically responds to topical steroids and generally recurs on investigation. The MRI brain and orbit, it is very important to repeat those investigations, because at the time of your the visit of the patient, he might have a normal MRI, but in a PVRL sometimes they have a positive MRI after some months. So there is a rule of 1/3 which says that 1/3 of patients with PVRL have only ocular, 1/3 of the patients have CNS but no ocular, and 1/3 have both. And it is always best to stop steroids prior to any biopsy. And the fourth challenge is what we called as pathological diagnosis. Why we call it as a challenge? Because the eye itself is such a small organ, and the samples that we send across to histopathologists is such a small quantity that sometimes it gets lost. And many a time they don't pay quite good attention to our ocular samples. So, but how does pathology help us to diagnose cases which are really tough and which really has flabbergasted us? There are few cases to show that. So this is a case which was referred as a extensive scleritis to me, but this was a young patient. He was a 28-year-old, and the right was again 32 to 33-year-old. So he had extensive chemosis. The entire anterior segment was filled with heme. There was no no view of anterior segment as well as posterior segment. Extensive pain, and if you see the ultrasound, he's showing a typical lesion which is very suggestive of probable melanoma. And if you go ahead and do an MRI which contrasts, which is 100% showing that T1 it is hyper and T2 it is hypo. So this is the entity which is very commonly seen in India, but it is underdiagnosed, and it is called as a spontaneously necrotic melanoma. And these spontaneous necrotic melanoma are especially seen in young people. In India as such, the age of melanoma diagnosis is early when you compare it to Western countries. And this spontaneous necrotic melanoma is seen mostly in young people, where the tumor grows so fast that it outstrips its blood supply. And so I can't take it. So it undergoes necrosis and it presents with severe inflammation. So on enucleation, when we did, it was typical suggestive of a melanoma. So this is another case in which this case has been shared by Dr. Vishal, and it is an interesting case in which the patient was there's a large lesion, yellowish lesion, ill-defined lesion, which is seen in the temporal aspect of the left eye, and it was being diagnosed as a scleritis and treated with oral steroids. But if you see the ultrasound, it is typically showing the features of melanoma. And the FFA, and most common is this OCT. Again, when I'm talking, OCT is very typical of melanoma. The melanoma is the back shadowing. These are shaggy photoreceptors which you are seeing in the underside of the detached retina. So this was a biopsy was taken from that lesion, and the biopsy was proven to be a melanoma, a melanotic melanoma. So very important is again that you have a clear communication with the pathologist before you start the surgery, so that he knows what you are sending, how you are sending. Number two is how do you send? Sometimes you send the sample in a formalin, which is absolutely no in a case of a PVRL. And how do you do a vitrectomy in PVRL? It should also be known. And most important is that always have an ocular biopsy ready in case the etiology is not clear. There's no point beating about the bush by trying this and that. My last challenge is the treatment. It's just a slide to finish it off. Is that treatment in case of a masquerade is always multidisciplinary. You alone cannot treat it, and you need on board the pathologist, the physician, and many other people who will help you with the diagnosis. So most important is to make the patients understand that if today, especially in metastasis and lymphoma, that lymphoma is always a systemic lesion. It's only that sometimes it gets involved later on. So it is very important to make them understand that even if today you are fine, it may occur in you tomorrow, and you may lose life. So that is very difficult to make the patients as well as the attenders understand. And most important, there's no fixed treatment parameters in a lot of cases, like in metastasis or a lymphoma. So treatment can vary with the same pathology in the same patient. And it is very taxing. It is very taxing for the doctor as well as for the physician because, as I said, patients lose. And most important is the follow-up, which is the biggest issue. So to end it, I'll only say in masquerade, the most important thing is that what the eye doesn't see and mind doesn't know, it doesn't exist. Thank you so much.
Thank you. That was a very extensive talk. Thanks a lot, Dr. Vikram. Can you hear me?
Yeah, yes, ma'am.
Yeah, that was a wonderful talk. I have just one very simple question, which I'll ask Dr. Vishali. Which are those anterior segment inflammations which are seen in masquerades? Like in which kind of, like an anterior uveitis or episcleritis, which could be actually a masquerade syndrome? Anybody on the panel?
Yeah, retinoblastoma can present with a very peculiar hypopyon and neuroblastoma. It will be like a round balls as a hypopyon. That is very, very important.
Even leukemia, I suppose, no?
Leukemia, yeah, absolutely. Leukemia can have hypopyon, and leukemia can have hyphema tinged hypopyon.
Yeah.
And also ciliary body melanoma can give hyphema.
Yeah. Partho, any question before we go on to our last speaker?
No, we can go to the next speaker already.
So our the talk was excellent, Dr. Vikramjit. A very challenging talk. We shall now go on to our last speaker, Dr. Anup Kelgaonkar, who's a consultant Victoria Retina Services, UVEA and Ocular Immunology from LVPI Bhubaneswar. And he's going to be telling us about the 5 challenges with ocular syphilis. On to you, Dr. Anup. Can you share your screen?
Yeah, is my screen visible?
Yes, just make it full.
Okay. Yeah, so I will keep my video off. I have poor network, it seems. The audio is fine?
Yes, audio is fine.
Yeah, thanks. Thanks for the opportunity for giving me this opportunity to present. And I would be discussing a very interesting disease that I like a lot, and that's syphilis. In fact, it's a fun that I have seen more cases as an ophthalmologist than as a MBBS student back in the MBBS days of syphilis. So these are the 5 challenges that I think that we all as a group face, and especially the ones we deal with the inflammation of the eye. The first is that syphilis tends to have a very wide spectrum of presentation and has an ability to affect almost every tissue of the eye. It's a great masquerader in that it is known to mimic known patterns of uveitis, the patterns with which we diagnose various diseases, as earlier speakers were pointing out to ARN-like presentation of syphilis, so on and so forth. Then there are these atypical and unique presentations which might not be there in the theory or existing literature. Syphilis also tends to have relationships with HIV and tends to have co-infection with this disease, which would change the course of either of the disease. And the fifth and foremost is many speakers have highlighted today the need of TPHA and VDRL in the testing of uveitis at baseline, and sometimes we get a TPHA positivity in otherwise non-suspected cases, and that's a big problem. I will briefly go through each of these challenges. I spoke about wide spectrum of presentation, and as one can see on the slide, from the front of the eye to the back, this organism can almost infect and affect each layer. I'll be focusing on a couple of cases that I had seen. This was a 42-year-old male with high risk sexual behavior who has had multiple recurrences of uveitis in his one eye. His TPHA and VDRL was both reactive, and he had iris atrophic lesions in addition with the posterior uveitis that he had. So this has been one of the features where iris atrophy with anterior uveitis might be seen with or without posterior uveitis, and screening such patients for for TPHA VDRL would be quite prudent, especially if they have a high risk sexual behavior. Again, this is a second case where he was a 34-year-old male, earlier undiagnosed HIV case, and we can see that there is an equatorial scleritis. The patient presented with pain, and there is also some amount of subcutaneous fluid or chemosis. Of course, there was a large retinitis lesion posteriorly, and this patient had TPHA and VDRL both reactive, and we tested for HIV in conjunction with this serological test for syphilis, and it was positive as well. He also had high-risk sexual behavior, as I was pointing out earlier. Again, just a photograph of intermediate UVEA test in which we also need to screen for syphilis, since we might not be able to see the posterior placoid or pre-retinal precipitates that have been described, and often a history along with blood investigations are of great help. Now coming to the second challenge that we face is it's a great masquerader, meaning it can mimic or disguise many known patterns of uveitis. If you see here that there is this acute retinal necrosis like lesion, which we thought earlier as ARN treated on similar lines and did not respond. It was only after about a week that we had to revise our diagnosis and take help of blood test, and this was indeed a case of syphilis. This was back years back, and then of course, as we know, we have TPHA VDRL in our testing panels nowadays. Again, a case of juxtapapillary retinitis along with focal areas of retinal vasculitis, which could be easily diagnosed as toxoplasma, since that being a most common cause of posterior uveitis or focal retinitis rather. And this case indeed was one of syphilitic chorioretinitis. Then there is one more case which I would like to show. For this case is of skip vasculitis, and everyone would have different interpretations on this. But if you see a subvascular lesion and a perivascular infiltrate, we'd be thinking more on lines of maybe tuberculosis or sarcoidosis. And this patient indeed had syphilis as well, and had a placoid in the other eye. Similar, we can have occlusive retinal vasculitis as a presentation of syphilitic posterior uveitis, and sometimes a very small placoid and pre-retinal superficial retinal precipitates rather are pointers towards such a diagnosis of posterior syphilis. Third challenge that we often have is atypical or very unique presentations of syphilis. Cases in which we might not think of syphilis in first go, but they indeed are such manifestations. I encountered one such case a year ago when a young patient, previously undiagnosed HIV, presented with nyctalopia. There was acute on chronic presentation where there was pigmentary retinopathy changes, and I could see multifocal choroidal lesions. Very few of those were actually active. So this was a beaded pulse-like presentation wherein I could see multiple small choroidal lesions, predominantly across the vessels, and once in the periphery were active along with vitritis. This case, this young guy tested positive for TPHA VDRL, and as I was mentioning earlier, he was previously undiagnosed HIV, and we started the treatment for both of the diseases. So far in this presentation, I have been mentioning HIV a lot, and syphilis tends to have a very close relationship with this disease, and many times we could be the ones, ophthalmologists could be the ones who diagnose a patient as having HIV if we see a morphological presentation of syphilis or make a diagnosis of syphilis. So there are many cases across literature, and all of us have seen as well that we are in fact the first doctors to diagnose HIV or AIDS in such group of patients. The course of HIV and syphilis do have an influence over each other, especially when HIV patients land up into AIDS, or they lose the cell-mediated immunity, is often said to be a time when there is an activation of syphilis or affection of the syphilis in the posterior segment of the eye. Also, if we have this dual diseases in a patient, we need to go for a multidisciplinary management. We will be wanting to have very close contacts and refer the patient to and fro from AIT center, physician, and us, which is at times a challenge in itself, especially for rural patients or those from low socioeconomic background. As again, if we are the ones diagnosing this disease, we need to start again systemic therapy of heart in association with especially a very good network of AIT centers that we have in India, along with IV antibiotics. This case, the representational case that I have put behind on the screen, was in fact a very large 10-disc diameter of full thickness retinitis with a posterior hypopyon in an earlier undiagnosed case of HIV. The fifth problem, and this is a slightly controversial one, is the problem of positive TPHA. Now, TPHA is said to have very high both specificity and sensitivity, and there is rarely a possibility of getting a false negative report. It's said to be 95% plus of both specificity and sensitivity, depending upon the lab in which we are doing. And at times, the specificity could be 97 to 99%, and sensitivity round about 95 to 97% as well. So there are very less possibilities when there could be a laboratory error. However, we do get some cases once in a while, and I would discuss one such case in later slides, which could have such a error. The second possibility is that of a co-infection. So a case of high-risk sexual behavior having any other disease, there is always a possibility of co-infection or an old infection. And a third possibility is that of endemic trypanomatosis diseases like AIOS, Pinta, and others, which are not sexually transmitted, but they can have a positive TPHA for life. So there is this one such case that I wanted to show, was a case of occlusive retinal vasculitis in a young male. He did have a history of high-risk sexual behavior, and interestingly, the TPHA was positive, VDRL negative, HIV non-reactive, and on a tubercular side, he had MAN2 positive, quantiferon negative, and chest did not have any lymphadenopathy on chest CT scan. What we could see were old subvascular lesions and neovascularization. We had lasered this patient, and there was retinal vasculitis, which was subvascular in location, along with occlusive vasculitis. And here's the question that we do: that what do we do for such cases? And what we did do was go for the treatment of syphilis first, intravenous antibiotics, and look how was the resolution of the retinitis. And this retinitis resolved very less as compared after the treatment. We did extend 2 to 3 weeks of doxycycline after completion of IV antibiotics, and patient continued to have retinal vasculitis, newer lesions, and we ended up giving him anti-tubercular therapy, where after which he did not have any other recurrences. Interesting to note here was the other eye was already lost to untreated tractional retinal detachment and anterior segment having neovascularization. So the left eye was an absolute eye. So maybe there was a small hint there that if there is a very long-standing disease with signs of chronicity in other, with not an acute presentation like syphilis, we could see overlap of two diseases. The patient might have systemic syphilis. He did have skin lesions in past. So that is again a possibility given his high risk behavior. So this was one point that I wanted to bring forward, that sometimes systemic co-infections, not retinal per se, are a possibility, and it becomes extremely difficult to say what this particular infection could be. This is a second lady, a 57-year-old lady who had disc involvement along with multiple variable size choroidal granulomas, and one of them was around about half this diameter. And this patient had MAN2, interferon, and HRCT, both, all the three things positive. However, baseline TPHA was positive. We repeated the TPHA along with VDRL, both of which turned out negative from another lab, and she received treatment for antitubercular drugs and had a very good outcome later, with no evidence of syphilitic lesions either on the follow-up, which we have been seeing now for almost a year or so. Those were the 5 challenges. And last, what I was mentioning was AIOS, Pinta, and other endemic trypanomatosis could have a lifelong positivity for TPHA. And if we encounter such cases, we should check childhood scars in the skin. Luckily for us, in 2016, we have been declared a AIOS-free country. But even then, those who have had infections in their childhood or in their later parts of life till this decade could have a TPHA positivity, and checking for skin scars is one way to look for old healed endemic trypanomatosis. Thank you.
Thank you very much, Dr. Anup. That was a superbly wonderful talk. I wish I could add more adjectives to it. So much of learning. Just one question to Dr. Rohan. Would you want to do a lumbar puncture in a case which has only, to rule out ocular syphilis in a case which has only eye symptoms?
You need to unmute yourself.
Okay, sorry. Yeah, so if the clinical picture is quite suspicious, like a placoid chorioretinitis, and both TPHA VDRL are positive, yes, it may have an element of neurosyphilis, but if there are no symptoms, these days we have stopped doing an LP in all cases. Earlier we were, yes, doing in all cases, but now we have stopped doing an LP and we generally go ahead with the systemic therapy. I just wanted one question for Dr. Anup. In your interesting case, which you showed where your TPHA was positive but VDRL negative, the first case where you finally treated with ATT.
Yeah.
Did you give steroids also along with it?
Steroids were not given initially when we started treatment for syphilis, but when we switched gears to ATT, we went for an ATT monotherapy rather to look for response. Since we thought if we did give Visalone with that, we would have not a clear response. So yes, after completion of the 2 weeks of ceftriaxone that we gave in that case, followed by 2 to 3 weeks of doxycycline, he had a very poor response, and there were newer areas of retinal vasculitis. We started with ATT monotherapy and saw for a response at 2 weeks, and he had a very favorable response by the end of 2 weeks. So we did not later add a oral steroid.
Okay, that is something which I would say is not as per my experience, because mostly I would say this response would come with steroids and ATT. And something I think many of us have started thinking of too much of TB, and these cases are probably like more of an immune reaction rather than a tubercular infection per se. But I think I'll leave that to open discussion because there is too much of controversy involved in that. So, thank you.
Anybody else has a point to bring forward? Dr. Ratnam, Dr. Vishali, Dr. Kosi.
One more challenge in syphilis, especially in syphilis, is history. History is not at all reliable. 2 days back, we had a patient with, he had all religious symbols in his forehead, and TPHA and the VDRL was positive. And he was so shocked. He told, "You are saying that I have sexually transmitted disease." No, he almost started shouting. I told, no, I am not saying only lab tests have come positive. We will do FDA ABS. And that was also positive. Then he became quiet and he told, I had contact long back. So history is very, very unreliable. That is also one more challenge in syphilis.
Mosquito bite.
We never, Dr. Basu has joined us late, came in and went back. So I think we should plague him with a lot of questions and discussions.
No, I'm sure people want to go back now. It's been a long day for everyone. But any questions? I'm really sorry. My OPD ran till 8 o'clock. I just couldn't.
Yeah, I can see you are so tired.
Very tired. Dr. Partho, you have anything to ask before we conclude?
I think Dr. Sudarshan can add something because he is the syphilis and HIV.
Mosquito bites.
Mosquito.
I mean, I remember one, like I used to put initial days, like I wish we are lucky that mosquito bite doesn't transmit HIV. Like, so what if it had transmitted? Like this, they were talking about characteristic syphilis lesions. I mean, syphilis is so atypical and varied that like you can't pinpoint one characteristic. This placoid lesions, one thing we've seen is if your immunity is better, or if you are immunocompetent, or if your counts are higher, then you get the placoid chorioretinitis. But if it's if your counts are much lower and immunosuppressed, then they come more as diffuse retinitis like lesions. So the in lower CD4 counts are immunosuppressed, you don't get the placoid chorioretinitis that often. And one thing in HIV is, I keep repeating this, even if low CD4 counts are there, then you can still have significant inflammation in syphilis patients. So usually with low CD4 counts, you don't get significant inflammation. But syphilis and toxo probably are two things, especially syphilis. Quite a few of us have reported vitritis or panuveitis as the primary presentation of ocular syphilis and HIV. So if unexplained vitritis or panuveitis in HIV positive, then one of the top DD is syphilis.
So can I ask a question here? I think it'd be useful because, you know, the point that Anu brought about apparently false positive TPHA, because it could be a true positive, but not related to the uveitis that we are dealing with. We have faced this quite a few times. Some of those occasions we repeated it from another lab and then it came out negative. But right now, for example, I'm dealing with a patient who is, you know, undiagnosed HIV, came to us with ARN, like picture bilateral ARN, and we did a biopsy. All the viruses are negative. Yet initially we thought he was responding very well to a full dose of valacyclovir. After that, now it's been nearly a month. The response has hardly been enough, and he's been on heart for 3 weeks now. Incidentally, his TPHA was also positive. Now, one of my understanding is that
his understanding is incomplete.
In such cases, if you're not sure if you're TPHA active, yeah.
No, we didn't get the last part.
Yeah. No, I was saying that if the VDRL is non-reactive, and in such cases where you're not sure of the diagnosis, then, you know, you could probably ignore the TPHA result. Now, this fellow is a HIV positive patient and his VDRL is non-reactive. So should we consider that aspect in this patient? The morphology of the lesion is typically like ARN, just like a standard ARN picture.
This is quite tough. I mean, I've been promoting, if you can call it, that you can still do intraocular specimen evaluation of the titers. There have been reports of vitreous sampling of the TPHA and RPR titers. So probably you can, with the same sample, you can test the titers and see. I mean, it is not some ubiquitous titer. It's not like torch or anything where it will be incidentally found in the vitreous or aqueous. If you get high titers and reducing ones with treatment, then probably it is ocular syphilis. You must be having the sample. I think maybe we can try checking the titers in that.
Darshan, can we have just interior uveitis in syphilis?
Yes.
So then the standard teaching of that we should not investigate any primary uveitis. then we should investigate for HIV or syphilis. It can present as the first uveitis.
No, that is a old statement.
So all uveitis to end, that is we should investigate all uveitis whether it is the first.
Yes.
Yeah, I remember Dr. Vishali telling in one of the webinars that it's a very old statement that first non-granular matters, then you don't need to investigate. I mean, you find a KP, you investigate, or you find anti-rebative, you investigate.
Famous saying by William Osler: "He who knows syphilis knows the medicine." So I think saying like he who knows the syphilis knows the entire uveitis. If you go through the recently published Sun classification criteria, they have recommended syphilis testing for all the clinical entities. The first criteria is the absence of serological diagnosis of syphilis.
Thank you.
Yeah, I think we would need to conclude. And I think first and foremost, I would like to say that we actually finished on time and with such fantastic talks and great discussions. And I'm sure each of us have enjoyed. We didn't even realize how these 2.5 hours passed off, and with so much of beautiful talks which were said. And really need to thank the expert panel and the great set of speakers who got here. And I need to, of course, thank my ARC and Srinivas Joshi, because he had a lot of work for this ISMI's conference. And my very, very, very special thanks to Dr. Partho. And I need to tell all of you that it was Partho who put together this beautiful session, the speakers, the talks. And even when I first had a glimpse of it, I knew this is going to be as interesting. A couple of months back itself, he told me that he would do it. And truly, thank you, Partho, for your wonderful insight to how to deal it a little differently and make it so interesting. I owe my thanks to the AIOS admin, Mr. Kripal and his team. My thanks to Sai and Manjula from Numerotech for all the mails which come across to your inboxes. And my very, very, very special thanks to Entod for being our sponsor for every single ARC webinar from the time of inception since COVID had started. And finally, and most importantly, we need to thank our delegates. I'm sure Mr. Sunil will tell us the numbers at the end of it. And it's that which keeps me, although we have started our physical meetings too, I feel that webinars should stay on, because at no point of time we could get such wonderful speakers and wonderful expert panel on the same podium. And thank you very much, all of you. Thank you so much.
Thank you.
Thank you, ma'am.
Thank you very much.
Partho, you want to add something?
Nothing to add.
Thank you, Partho. Thank you very much.
Thank you.